PPT is already connected.
Is it fine? ரைட் சைடு ஏதோ லெஃப்ட் சைடு ஏதோ கரெக்டா அந்த காதுல கரெக்டா உட்காந்த மாதிரி தெரியல.
Hi, can anyone hear me at Madras Medical Mission?
Yes.
Oh,
Can you
hi.
hear me, sir?
Yes, we can hear you. I'm from Dhaka National Heart Foundation. It's from the control room.
Okay. You are able to hear me very well?
And the audio is a bit too loud. If you can
Okay.
reduce the level a bit down.
No, I will speak softer. Now is it better?
Can you speak again, please?
Hello, welcome to all of you in the National Heart Foundation annual conference. I am Dr. Shivakumar from Madras Medical Mission.
Yeah, good. Thank you.
Perfect. So at what time we are, the time that has been given to us is to go live in another maximum 10 minutes. So can we go ahead with start in 10 minutes?
Let me get someone who can answer that because I'm from the technical crew team.
Okay.
Let me get someone. Hold on.
Okay. Can you put the aortic pressure line? 7,000. Okay. Pressure RCA.
Anatomy, sir.
Sister. இது
பார்க்கலாம்.
கொடுங்கம்மா.
அது decide.
சாதா வயர்மா. What is the size of the ASD, Prabhu? Pramod?
Sir, actually in balloon sizing we got quite
20, but what is the size now?
This actually this
0
anatomy is
degree?
quite weird.
Go to 0.
Yes, sir. 0, sir.
Okay.
Zero. The anatomy
Sir,
is
good afternoon. I'm Dr. Taufik here, sir.
Hi, Taufik. How are you?
Yes, sir. Yes, sir. Fine, sir.
Okay.
People are just coming in after lunch.
Okay. Fine.
Can we start in 5-10 minutes, sir?
Yeah. 5 minutes. We'll be ready.
Okay, 5 minutes. Okay, sir.
Sir, anatomy.
Pull out, Pramod.
Yes,
Pull
sir.
out, Pramod.
Yes, sir.
Pull out. Further. Now clockwise. No, give it. Be in 0 degree.
Yes, sir. 0 degree, sir.
Okay. Pull out. Rightward torque. Okay, that. Now only you are getting. Color now. That is right pulmonary artery. Color. The top one. That is a pulmonary vein.
This is pulmonary vein.
Okay. Now slightly leftward. See, that is the ASD.
Yes, this one.
Color out. Slightly go inside. Why is the probe? Why is it just so much distorted?
Yes, sir.
Now
The
let me
anatomy
see
is
whether
quite
you are
distorted, actually.
angulated a lot.
Sir, fluoro.
Show,
Man,
Prabhu,
chest
you are
காட்டுங்க.
fluoro.
Looks decent, sir.
Slightly go inside.
Yes, sir. Here we already tricuspid is
No,
tricuspid.
this is looking like,
It's like a mitral.
correct. What is the
Okay.
problem? Let me see.
Why is it inverted? No, it's not. Yeah.
Enter the
right,
RA,
left is
record the RA
inverted,
pressure
no.
and all.
Right left was inverted, sir. Sorry.
Huh?
Right left was inverted, sir.
Okay.
Okay, I'm coming above.
Right.
Yeah,
Let me see one picture
Yes,
and
sir.
then I'll.
Yes, sir.
Okay, this is the ASD.
Yes, sir.
Okay. Now, four-chamber view also. See, you
four-chamber
here
is
you
okay.
show that the RV is small and the
yes, sir.
LV is big. You show that there is a mild mitral regurgitation. Then you show that there is a dilated coronary sinus here.
Yes, sir.
And then you go to long axis, 90 degree, and show that this is that coronary sinus divertic.
Yes, sir.
Huh? This is the LV, LA, this coronary sinus divertic. This is the flow in and out of that coronary sinus.
Yes, sir.
You can go back to 0 degree. RI mean is how much? So ஒரு glove கொடுங்கம்மா.
सही सर हाँ सर ना पता मैंने देखा नहीं सर देख लेता हूँ 1 मिनट
Cross the ASD. Let's put in the stiff wire and get. Okay, go inside. Go inside. Just push it. Clockwise start. Push. Okay, wire. The previous position was appendage. Go inside. It's lower pulmonary vein. Go inside. Take it out.
We are starting with like when we start we will be in the we will have already crossed the ASD and
Yes,
Yeah.
sir.
Yes,
Razak sir, আমাদের join করেন। Sir, good afternoon, sir.
Good afternoon.
Thank you very much for taking the pain to join with us. So amid the scare of this new variant, still we are having a hybrid conference. Sir, we have Professor S.K. Razak sir with us. Salam sir is going to join with us. Rima, Dr. Rizwana Rima, and Dr. Somaira will also join. Sir, I think for the sake of time, so you can introduce us with the case and start.
Thank you, Dr. Taufik, Dr. Razak. It's a pleasure to see both of you on the chair. I am audible.
Thank you. Good afternoon, Professor Shiva Kumar.
Nice to see you, sir, and nice to see Dr. Rizona also joining the chair. It's a-
Everybody is coming, and Rejwana is also with us. And
It's a
everybody is
pleasure
coming.
to again see all of you. Bangladesh is like my second home. So thanks for the opportunity to come live with an interesting case.
Okay,
Let me
carry
have
on,
the-
friend.
Let me have the PowerPoint on, please. I will the story of this man. It's a 54-year-old gentleman who had mild polycythemia with a hemoglobin ranging between 16 to 17 grams per deciliter and some dyspnea on effort. During this COVID pandemic, when pulse oximeter screening was routinely done for many people, his saturation was 82. He was suspected to have a COVID. He was investigated with CT scans. The CT did not show any lung abnormality, and subsequently he came to our medical attention. Next slide. The past history is he had hypertension and dyslipidemia. He developed an anterior wall myocardial infarction in 2010, which was thrombolized with retiplase. And then they did a coronary angiogram in 2010, did not show any flow limiting coronary atherosclerotic disease. In 2017, he underwent bariatric surgery with a weight loss from close to 110 kilogram to 70 kilogram. During this time on clinical examination, his pulse oximetry was 82 to 85%. He had a mild polycythemia with a hemoglobin of around 17. The JVP was not elevated. There was no pedal edema. Pulse blood pressure were normal. CVS did not show any significant murmur. Next slide. The chest X-ray and ECG were also largely unremarkable. An apical four-chamber view was done, which showed what you are seeing in the picture. There was a little larger left ventricle. Mitral valve was normal. The parasternal long axis, left ventricular systolic contractility was normal. Mitral valve was normal. Next picture. On an apical four-chamber view, when the posterior part, when it was swept, there was some submitral sac. You can appreciate just below the mitral valve, a sac-like thinned structure. So it was unclear what this structure was. Next picture. Because of the cyanosis, a contrast agitated saline was done. I will place my greetings to Dr. Salam, who is just entering the podium. Salam sir, good morning. Good afternoon. So now we observed that there was a free spillover of the contrast, agitated saline contrast into this left ventricle. You are now seeing the left ventricle filling with contrast. This indicated that there was an intracardiac right-left shunt. Next picture. So the inferences that we got from the echo was LV was large, but LV contractility was normal. There was a submitral sac-like pouch posteriorly. There was a contrast echo filling the left atrium in the first cycle, indicating an intracardiac right-left shunt. The patient's clinical presentation was dyspnea, low saturations. Next slide. So with this unclear submitral sac and an unclear reason for a intracardiac right-left shunt, a cardiac MRI was planned. This MRI was primarily to identify what is that submitral sac. This is a first pass gadolinium study with the injection of the gadolinium from the left cubital arm vein. You observe that as soon as the left cubital vein, superior vena cava and RA fills, immediately there is filling of not only the RV and PA but also aorta immediately, which means from the right atrium, the blood is equally getting distributed to both pulmonary artery and aorta without a delay. This is almost like an equivalent of the contrast echocardiogram. Next slide. On a four-chamber view on the cardiac MRI, we found that the LV was dilated. LV contractility was normal. There was a tiny midmuscular VSD which was very insignificant, just around 1 to 2 millimeters. RA was dilated. Next picture. In the short axis of the left ventricle, the LV contractility was normal. Can you play this picture? Can you click on the movies? Just go inside and click on the movie. Yeah, this is the left, the other movie also. So this was the contractility of the left ventricle, but in the first image again click, we will find that there is a below the basal part of the left ventricle, there was a submitral, a sac-like structure. This sac was not communicating to the left ventricle. Next picture. So the MRI was done. MRI, the values, left ventricle was indexed volume of 91 ml, little on the higher side. RV indexed volume was 47 ml, little on the lower side. Next picture. The MRI flows across the aorta and pulmonary artery. Pulmonary artery flows were marginally less than the aorta. Next. So this is that submitral non-contractile sac. This is a long axis of the left ventricle with a non-contractile sac at the basal part of the left ventricle. This was not communicating to the ventricle. It was communicating to the right atrium. So we thought that this is a dilated coronary sinus. Next picture. This is that submitral sac. This was communicating with the right atrium, and the left atrium, left ventricle flow was normal, and the left ventricular contractility was normal. Next picture. This was a CT scan which shows, is a running movie from bottom to top. LV is dilated, RV is little smaller. There was a submitral sac. Again, next time when we come, you see that. There was some coronary atherosclerosis calcifications, but already a coronary angiogram that was done previously was normal. Now concentrate on the next run when it comes. That place now, that is a submitral sac. Next picture. So after all this imaging, what we knew was there is a right to left intracardiac shunt on contrast echo as well as contrast MRI. LV is large, RV is small. There is a submitral sac-like structure which is communicating to the right atrium, possibly a coronary sinus. There was no mitral regurgitation. The patient's problem was breathlessness, low oxygen saturations. Next. So we did an angiogram, a diagnostic angiogram. The catheter easily went into that sac. This sac was a large coronary sinus diverticulum. You can appreciate the catheter from the right atrium is entering into that sac. The distal part of the sac is a normal coronary sinus and the great cardiac veins, but the proximal portion of the sac was a huge coronary sinus diverticulum. It was filling only the right atrium, and this coronary sinus diverticulum was not the cause of desaturation. The desaturation was not due to this, because when we are injecting into this coronary sinus diverticulum, the left heart is not filling. It fills the RA and RV. So this is not explaining the right to left shunt. Next picture. This we went in deep into the coronary sinus. The distal parts of the coronary sinus was completely normal. The proximal part of the coronary sinus where it is entering into right atrium was having a large diverticulum. And click on the upper figure. So here we can see that the anterior cardiac vein is continuing into the coronary sinus. The entire coronary sinus was normal except in the most proximal portion where there was a diverticulum. Next picture. This is an RV angiogram in LAO cranial projection and a simultaneous LV angiogram in a, we can appreciate a tiny midmuscular VSD, which was not significant. The VSD was hardly measuring about 2 millimeters. But LV was dilated, RV was smaller. RV contractility was normal. So this RV hypoplasia then probably was the presumed reason for the right to left shunt across an atrial level communication. Next picture. This is the RV angiogram on an RAO projection which shows a normal RV contractility. No feature suggestive of any RV, endomyocardial fibrosis or any other RV pathology. The ASD, we put in a balloon and we sized it. It was around 20 millimeters. So we had an ASD, but this ASD was not shunting left to right. This ASD was not showing any clinical features of an ASD. There was no outflow murmur. There was no right heart dilatation. There was no PA dilatation. But this ASD was causing a right to left shunt because of the marginal RV hypoplasia, which resulted in hypoxia and that led to breathlessness. Coronary arteries, even though there were some calcification, there is no flow limiting stenosis. Coronary angiogram was not suggestive of any myocardial ischemia. Next picture. A detailed hemodynamics was done. SVC and IVC saturations were around 59 to 60%. The PA saturation was 66%. There was a step up of around 6% in the pulmonary artery. The pulmonary veins, this was in the awake state, the pulmonary veins had a saturation of around 94%, and the aorta had a desaturation to 87. There was a step down of 7% from the pulmonary vein to aorta, which indicated the quantum of right to left shunt across the ASD. And there was a 6% increase in the step up from the mixed vein to pulmonary artery, indicating the left right shunt. So there was possibly some amount of left to right and some amount of right to left shunt across the ASD. The RA mean pressure was 8, RV pressure was 35, PA pressure was 25/7 with a mean of 14, normal pulmonary artery pressures. Because of this 20 millimeter ASD, LA pressure was also the same. Aortic pressure was normal. The calculated QP and QS were 2.2 and 2.3, not much of difference. There was a balanced amount of right to left shunt and a left right shunt. Next picture. So finally now, at the end of the clinical evaluation, we had a patient who was cyanosed, mild polycythemia, low saturation, possibly secondary to hypoplastic right ventricle and a 20 millimeter secondum ASD shunting right to left. The reason why I made a detailed history so far, this patient never showed a clinical feature of an ASD with a left right shunt, no flow murmurs, no wide split second heart sound. There was no right ventricular impulse, no RV volume overload. That was the reason why an ASD was not suspected in this elderly man of around 54 years. Incidentally, he had a coronary sinus diverticulum, which appeared as a submitral sac in some of the echocardiographic images, which was pursued further and further with lots of image, but this was not contributing to the symptoms. It was a benign coronary sinus diverticulum, but without any arrhythmia. Usually coronary sinus diverticulums have WPW syndrome. He didn't have anything. There was a tiny midmuscular VSD, which was an incidental pickup. This did not produce any clinical murmur at all. Coronary angiogram showed no flow limiting stenosis. So we had an interesting patient who has a secondum atrial septal defect, which is shunting right to left with a hypoplastic right ventricle. And this hypoxia is causing breathlessness. Hypoxia is causing effort intolerance. So this is the story now. So questions, Dr. Rizona, Dr. Salam, Dr. Razak, and then I will show I have with me Dr. Sandeep Mohanty, who is from Odisha, who is assisting me, and Dr. Pramod Sagar, who is one of my very senior associate. He is doing the transesophageal echocardiogram live.
Sir, this is Dr. Rizwana. Sir, only hypoplastic RV can explain the right to left shunt, or there is some RV dysfunction as well?
Actually, the RV contractility, as you saw in that angiogram, the RV contractility was quite brisk. A quantification of RV contractility by the cardiac MRI showed an RV ejection fraction of 74%. RV contractility was normal. RV volumes were at the lowest part of the normal centiles, and the LV was at the highest part of the centiles.
Sir, Shiba,
Yes, sir.
nice to see you in this pandemic. Virtually, you are joined with us. Congratulations and thank you very much from the faculty of Bangladesh. And we'll see you actually in next time, inshallah. And wonderful case, very rare case. I think I have not seen such a case, except one case where I think Dr. Momen is here. Is it here? He has done on ASD device closure in case of cyanotic patient having with pulmonary stenosis. But in your case, there is no pulmonary stenosis. But what about the functioning capacity? Already you have mentioned, but we want to know is the morphology of the RB is tripartite or bipartite? And
Yeah.
number two question is coronary sinus you have delineated, you have shown, but you have shown that there is a sac, and but angiography and MRI did not show any communication. So unroofed coronary sinus was another possibility of desaturation, but it is not there. So it is very peculiar to us to find out the cause of cyanosis and polycythemia, these all. So is there anything lacking or no finding? We are not lacking this finding. So how can we approach to
Yes.
further evaluate?
Just go back
the
to the,
cause
go
of
back to the,
cyanosis?
go back to the PowerPoint, please, once again. The PowerPoint once again and show the last 3 slides. Last, one, two before, one before, one before, one before, one before. One, okay, now run these two, click on both. So I will show the, I will start from Dr. Salam's questions. This is the right ventricle. This right ventricle now is showing a normal contractility. You can see that it squeezes normally. Now to see whether it is tripartite, we will now go to the RAO view. Next picture. Next picture. So this is the right ventricle. You can see the inlet, the body and the outlet. It has 3 parts. It's small. There is a secondum atrial septal defect, which is now balloon sized, which is measuring 20 millimeters. And this 20 millimeter secondum ASD is the cause of the right to left shunt. Now, the coronary sinus initially was thought to be unroofed coronary sinus was thought to be the possible reason. However, when we injected directly into the coronary sinus, we only saw the diverticulum. We did not see a filling of the left atrium. Go back two frames. Go 2 slides before. PowerPoint, go before, one more slide before. One more before. Okay, so this is the coronary sinus. We are injecting directly into the coronary sinus diverticulum, a huge diverticulum. It's not filling the LA-LV. We see that it's filling the RA and RV. So we recognize that the CS diverticulum, there is no CS unroofing, and that is not the cause. However, the hypoplasia of the right ventricle with filling of the right atrium to left atrium through the 20 millimeter ASD was the probable cause. Now the question here is, should we close that atrial septal defect? Whether the closure of the atrial septal defect will result in markedly elevated RA pressures, thereby leading to right heart failure, pedal edema for this patient. Because closure of the ASD will prevent hypoxia, closure of the ASD will prevent polycythemia, may prevent paradoxical embolism, might improve the effort tolerance due to improvement of the hypoxia, but whether he will tolerate that closure because RA pressure, whether it will go higher. This is the question that we have in mind. Go live to a transesophageal echocardiogram. Transesophageal echo live. Yes, sir. Go ahead, sir. Dr. Salam.
Yeah, and from your angiogram, it is not appreciable. The RB inlet portion is not well visualized, and RB is so hypoplastic, as well as there is no tricuspid regurgitation.
Okay.
So-
Now that question will be answered now on a live echocardiogram. Make the echo bigger.
Yeah.
Prabhu, make the echo bigger.
Thank you, Professor Shiva, for your nice presentation. It is a
Go into the fourth chamber.
actually the submittal sac is a coronary sinus diverticulum without any symptom. The main problem here is the hypoplastic RV with ASD and that creating polycythemia.
Yes. Now
And
this
your
is
suggestion is to close the ASD or any other surgical intervention of univentricular heart. Do you suggest that will prevent the future congestive cardiac failure post ASD closure?
correct. So the approach has to be, suppose if we do a occlusion of the atrial septal defect and the right atrial pressure is within tolerable limits, then this patient can just have a complete ASD closure. If the patient's right atrial pressure increases on an occlusion of this atrial septal defect, then he needs a bidirectional Glenn shunt to push half of the blood directly into the pulmonary artery and close the ASD so that inferior vena cava blood will come into the RA, hypoplastic RV and go into the PA. So the hemodynamics has to be checked when the patient is with the balloon occlusion, what is happening to the RA pressure. So we will now, this is the right ventricular inflow portion. The blue color flow that is shown by Dr. Pramod is that tricuspid valve inflow. There is no inflow gradient. You can see a mild tricuspid regurgitation. Without color also show, Dr. Pramod. So can you measure the tricuspid valve annulus and tell what is the tricuspid valve annulus? Yeah, that's a good picture.
So your option is half fontan and followed by with ASD closure.
Well, as I told, see this
Half
is
fontan will fontan will divert the RV volume through the SVC.
correct. Provided the RA pressure goes up on a balloon occlusion. On the contrary, if the RA pressure is not increasing significantly, if the increase in the pressure is only 2 or 3 millimeters of mercury, we will be able to manage it with little bit of diuretics, and then the right ventricle can be expected to give a overhaul and slowly accommodate to that additional volume. Now, tricuspid annular diameter is around 22 millimeter with a mild tricuspid regurgitation. Now, I am going to do a contrast echocardiogram fresh. So, currently, what we are seeing is a 4-chamber view. Now, I am going to so Dr. Pramod is now demonstrating. So now you can appreciate that the moment I fill the RA, there is immediate filling of the LA. So we are able to see the large mitral valve there. This is filling of the RA, RV, and at the same time LA-LV is also filling quite briskly. This indicates the quantum of right to left shunt, and this explains why the patient is having significant desaturation. In the room air, he was having a saturation of around 82%. Right now, he is being intubated and mechanically ventilated for the purpose of this live transmission. And at this particular level of ventilation, he is having a saturation of 90%. You are able to appreciate the right to left shunt through the contrast echocardiogram. So now what we are going to do will be a sizing balloon occlusion of the atrial septal defect. Already I have shown you the hemodynamics. The RA pressure was 8 and the PA pressure was, show the RA pressure also live.
Sir, this is Dr. Santosh.
Yes, Dr. Santosh, nice to see you. Nice to hear your voice. I'm not seeing you.
Sir, how are you, sir?
I am fine.
Sir, I have a query.
Yes.
So, is there any positional difference of saturation of this patient?
Extremely good question. What you are talking about is platypnea orthodeoxia syndrome.
Yes, sir.
Exactly. This particular patient has gone beyond that stage. He is actually having right to left shunt throughout. He is having a resting saturation of 80 to 82% throughout, whether he is standing, sitting, or lying down. So this was in a patent foramen ovale, where a difference in the direction of the flow from the inferior vena cava can alter the right to left shunt. You can have this platypnea orthodeoxia syndrome also in pulmonary AV fistulas. A good question. So now what I'm going to do is I'm going to do a balloon sizing. This is an Amplatzer sizing balloon. The sizing balloon is now going into the heart, and now I am going to the RA mean pressure. Put the RA mean. So the RA mean pressure is around 9 now. Put it on 20 scales. So now I'm slowly inflating. I have inflated and I am locking it. RA mean pressure change the color to yellow. They will be able to see better. RA mean pressure is now around 10 millimeters of mercury. Are you able to see the RA mean pressure? Dr. Salam?
Yes, sir, we can see, sir.
Yes. So now I am doing the repeat agitated saline injection. 4-chamber view. Get the 4-chamber.
Yes.
Okay, slightly. Okay, that's good. So now I am doing a repeat agitated saline injection. Now I am filling the RA. Keep watching. Keep on watching. I am giving more and more of agitated saline. Are you able to appreciate the contrast on the right side of the heart?
Yes, sir.
Taufik?
Yes, sir.
But on the left side, it is not coming now. Can you see that?
Yeah, yes, sir. We can see.
So I will demonstrate how I am doing an agitated saline contrast. Put it here. So what I am doing is, I am not giving any air bubble and all. You see what I am doing? I am just connecting to the venous chamber and I am aspirating and re-injecting. I am aspirating and re-injecting. I am not injecting any air. This will produce quite an intense contrast. Now go to Echo Live. Go to Echo Live.
Echo live.
You can appreciate that this is the contrast on the right atrium. On that side is the left atrium.
Yes, sir, we can appreciate.
Fine. So now what we understand from this maneuver is that the closure of this atrial septal defect with the balloon, which is completely occluding that atrial septal defect and not allowing any blood to go into the left atrium, is not resulting in a significant elevation of the RA mean pressure. Show the RA mean pressure big. You can appreciate that the RA mean pressure is still remaining at around 8 to 9 millimeters of
yeah,
mercury and it is not getting elevated.
RA mean pressure is 10, around 10, 9.
Yeah,
Eight,
maybe put it on 10
7.
scale. Yeah, around 8. Now I'll show it in 10 scale.
Yeah.
It's in better. It's in and around 8 to 9. More or less
Right.
this. Now I will do one thing. I am going to deflate the balloon and open this ASD. Now
Now it
my
is 11, 5.
I am opening this ASD again. Fully I am opening. Show the fluoroscopy. So I have fully opened it out. And now let me see the RA mean pressure. Show the RA mean pressure. It's the same around 8 millimeters of mercury.
Yeah.
Now what I will
Same.
do is I will
It's
do
almost
the
same.
more or less the same. So now
Right.
show the echocardiogram live bigger. So now I'm again giving that same agitated contrast. Now we are able to appreciate the right to left shunt.
Shiva,
Yes.
hello.
Yeah,
Shiva,
yeah.
do you like to go to RB to measure the pressure because there is some decompensation through the IVC and SBC of your RA pressure? So actual RB pressure should we measure?
Actually, sir, if suppose this patient was having a right ventricular systolic hypertension before, then closure of the atrial septal defect, we need to see what is happening. Now what we are doing is basically driving the RA blood towards the RV and the pulmonary artery. The entire blood is being driven. The right atrial pressure is what is to be measured here. The pulmonary artery pressure may not significantly be changed. However, I can show you that also. Put a wire inside. I will show you that also. Show echobic, fluorobic. Yeah. Fluoro. Go ahead.
Shiva,
Yes.
then your final decision is if we close the ASD by device, then the RA pressure will not significantly increase and shunt will shunt will be abolished and this saturation will be abolished. And
Correct.
patient will able to accommodate with this hypoplastic RV in future.
Correct, sir. Exactly, exactly.
This is the final decision of our
balloon occlusion hemodynamics.
balloon occlusion. Right. Thank you.
Exactly, exactly. You have hit the bullet.
Then
Go
friend,
inside.
thank you very much. We have 5 to 10 minutes also.
Okay. Actually, we could have started a little bit earlier also. I was waiting for your lunch to get over, and so we were. Okay, now I will show you. The closure part is relatively simple. So now I am going to re-occlude, and this is now the pulmonary artery pressure. Show the pulmonary artery pressure. I have again occluded the ASD now. Okay, I have a PA pressure. Show the PA pressure big. This is the PA pressure. PA pressure is not changing much. Now I am coming down to RV pressure. That is the RV. This is the RV pressure. Slightly elevated RV ED because of the hypoplasia. Now this is the RA pressure. RA pressure is same 8. This is in spite of the closure of the atrial septal communication. So as pointed out by Dr. Razak, in the next 2 minutes, we are going to close this VSD. Get a 12 French long sheet. So we are going to be using the balloon sizing was close to 20 to 21 millimeters. So we are planning to use a 24 millimeter Amplatzer atrial septal device.
Sir, the patient is ventilated. So once the
Yes.
patient awake, do you think the RA pressure will rise?
Basically, the same thing question will be very valid if it is left atrial. In the right atrium, there is nothing much to increase on an awake state versus a sedated state. In the left atrium, it is very important because the left atrium is a non-accommodative atria. And so sometimes in a fully anesthetized phase, you may have a controlled LA pressure as in a restrictive LV physiology. But when the patient becomes awake, there sometimes can be more increase in the pressures. Here what we are observing is that there is an elevated RA pressure. The RA mean of 8 is slightly on the higher side. However, it is not causing a substantial further increase when we close the atrial septal defect. When you look at the QP-QS, the QP and QS were almost the same, which indicates that the amount of blood that is going from the right to left through the ASD is being matched by the amount of blood that is left to right. So the heart was basically working at the same volumes before also. So now what we are doing is we are planning to get the 24 millimeter Amplatzer septal occluder device. Open the 24 millimeter Amplatzer device. What we used was a 34 millimeter Amplatzer sizing balloon initially. Now this is a 24 millimeter. Show the device to the camera. And we are going to use what is called as a Trevisio cable. Show the Trevisio cable. The difference between a Trevisio cable and a conventional cable is that Trevisio cable is very flexible. Show here. The cable is highly flexible. It allows a lot of flexibility at the screw end of the device. Flush this. Pramod, get the ASD open correctly. So now I am screwing the device to the cable. In Bangladesh, do you get this Trevisio cable?
No, sir, it's not yet available. Do you find
Okay.
it user-friendly more than the usual cable?
Well, we will see it now, how it works now. You can see the flexibility of the cable now. So this is, you see the flexibility of the cable, how it moves. So we have, there is a small cobra formation of the device. Let me get it better. Sometimes this cobra formation, we will be able to get it down with just manipulation. I'll just get it reshaped outside and then come back. Gently flush it out. So this is the cobra formation. Show it closer. Show it very close. Show the camera bigger.
Actually,
So I'm trying to,
RUPV approach এ কোবরা খুব কম LUPV তে বেশি LUPV তে বেশি ফ্যাক্টর আছে কিন্তু
the patient is gone into atrial fibrillation now. You can appreciate the fibrillation of the atria. Sister, give amiodarone 150 milligram. Can you appreciate the fibrillation
No, we cannot
on
see
the
the,
transesophageal echo bigger?
Yeah,
Transesophageal
yeah.
echo?
yeah. Now we can
See-
appreciate, sir.
Yeah, T big. Sister, 150 milligram amiodarone. So now show the ASD, Pramod. So now I am slowly bringing the device and approximating against that ASD. So the positioning is done. Okay. So the positioning is completed. Pramod, check the position. Electrical cardioversion, bring the machine closer. Giri, give a little bolus of amiodarone. Electrical cardioversion. Before release of the ASD device, we should try to cardiovert, and we should not try to cardiovert after release of the device. Show the ECG bigger, hemodynamics. Show the hemodynamics. Yeah. So this is the atrial fibrillation, and yeah. Or bolus. Get ready for 200 joules single synchronized shock. The device is in good position. Just to promote, confirm that the device position is fine. Get me. I am just repeating another contrast echocardiogram now. This is to just confirm that the right left shunt is to a large extent avoided. So now I am injecting on the right side of the heart.
You can Giri sir கொடுக்கலாம். You can give it to Giri sir.
There is a lot of contrast on the right side, but the left side by and large seems to be clean. Okay. Now, how much of amiodarone has gone in? 150 has gone in. Okay. Can you give one shock, 200 joules synchronized? Synchronize on. Okay. Get a good ECG and then. No, it's all full of artifacts. That ECG is full of artifacts. You get the paddle. So it's important to have the ECG perfectly synchronized for a cardioversion. So we are keeping the ECG for you. synchronize on 200 joules. Far vector. Move the vector far to the right. That one far to the left. Whenever we are cardioverting atrial fibrillation, it's primarily the atria that is being depolarized. Shock. (200 joules). Okay. So now he's in sinus rhythm. So now the hemodynamics are stable, sinus rhythm. Now show the echocardiogram, Pramod. You were able to watch the ECG as well as echocardiogram?
With the decision. After decision, the rhythm is sinus now. Shiva.
Correct. But it is going into flutter on and off. Can you see that it's going into flutter again?
Yes.
Okay. It probably, he might need a little bit more of amiodarone and a second dose of second cardioversion. So basically what I will do is in the next 5 minutes or so, I will give him another bolus of amiodarone followed by cardioversion. This time he reverted to sinus rhythm, but see now itself he's on and off trying to come out of that flutter, but amiodarone another 150 milligram.
Sir, excuse me, we would have
ahead,
to
go
leave
ahead.
you in 2 minutes, sir.
Yeah.
2 more minutes with you, sir.
Yeah. Give one more electrical cardioversion. Give this 150 and.
So I believe you're having the first cash training program in your center of excellence for the first time.
Yeah, it's going on now.
Yes, sir.
Actually,
So we are,
some of the doctors who are standing here are part of that meeting also. Behind me is Dr. Prem Alva from Mangalore, Dr. Sandeep Mohanty from Odisha. They're all from part of that program. And so as I am talking to you, Dr. Pramod is now showing the echocardiogram. Show the full nice 90-degree view. Rotate and show the other direction. Other direction. Yeah. Keep on rotating. Keep on rotating. Okay, fine. Give the second shock. Get the ECG clean there. People who are elderly are prone for atrial arrhythmias, and so it is possibly not surprising. The only thing that probably we may have to do is the strategy of anticoagulation after this procedure. Instead of dual antiplatelets, I might probably decide on anticoagulation, which is like a NOAC, rivaroxaban, or apixaban, along with low dose aspirin, because of one episode of atrial flutter, which was peri-procedural. As I talk to you again, we have converted him back into sinus rhythm right now. I'm not going to do any further contrast echo because it was the previous agitated saline contrast echo, a forcible injection that triggered again another episode of AF. I will maintain him on sinus rhythm with continued dose of amiodarone for maybe another few more months. So this is a demonstration of a right to left shunt ASD, which is being closed with a device. By
Dear
document-
Shiva, thank you very much for the wonderful case demonstration. From Bangladesh, we are congratulating and thanking you for this wonderful case. And I think we are at the end of the session. And from all the faculties as well as from the whole participant, we are again thanking you very much.
Thanks a lot. It's a pleasure to
And
join you all. Thank
Not
you.
but the least, my one question to you that what complication you are anticipating in future and how we will monitor this?
Now that he has shown up one episode of atrial fibrillation, he probably should be maintained in sinus rhythm with a drug like amiodarone for some time, and maybe after some time beta blockers. Number two is, since he is having a possibility of a thrombus formation because of this atrial fibrillation, maintenance of a proper oral anticoagulation is important, like either NOAC or vitamin K anticoagulation. And the third one will be since he has a coronary atherosclerosis as shown by some calcification of the coronaries, proper lifestyle modification of his hypertension, diabetes, hyperlipidemia, that also has to be maintained.
Normally, Shiva, normally our prophylaxis of with aspirin is usually 6 months. And what is your plan for these cases, especially for
This-
these cases?
This patient, I will probably start on aspirin plus apixaban or rivaroxaban, maintain for about 6 months. At the end of 6 months, if he is in sinus rhythm, continue aspirin lifelong.
Lifelong aspirin. Thank you. Thank you very much, Shiva.
Thank you very
Thank-
much. It's a
thank you,
pleasure to
sir.
join you all.
See you next year, inshallah.
Sure,
Goodbye.
sure. Thank you.
Thank you, sir.
Thank you. Pramod, you are happy about the position?
Yes, sir. Position is fine, sir.
So can I
So-
release?
Yes, sir.
Amiodarone
Hello, hello, hello. Can you hear us? This is from National Heart Foundation, Dhaka. Hello.
Hello, can you
Yes,
hear
sir.
me?
Yes, sir.
Good afternoon,
very-
everyone. Good afternoon. Am
Good
I audible?
afternoon, sir.
Good afternoon.
I'm Taufik from National Heart Foundation, sir. Thank you for connecting with us.
Right. Thank
Yes,
you
sir.
very much.
So, sir, it's a post-lunch session. We have just finished a live case from Shiva, sir. Now, sir, we are
Okay.
with you for a long time for a lecture, and probably you are going to show us a case in box.
Right. So I'll show the case in box. That will be a longer one. So I'll try
Sure.
to finish off my talk, which is based
Yes,
on the
sir.
hypoplastic aortic arch and co-operation of aorta.
Right, sir.
So this is today the first talk. I won't be showing, my only disclaimer is that I won't be showing you any interventions. I'll be talking on a subject which is not much discussed, and probably will we always try to come over the subject because this doesn't get much of an importance all the times. So I'll be talking only on the hypoplastic aortic arch and co-operation of aorta, where all it can be missed, what are the places where it can be missed, and what are the places where it should be paid more attention. Okay. So first of all, the learning objectives of this particular session is to assess the aortic arch objectively. I'll take roughly around 15 minutes of time, then I'll go to this thing. And to preempt whether the aortic arch can be left alone or needs interventions while repairing the other defects. So sometimes যেমন আমাদের অনেক সময় আমরা করি আর কি, যে ধরুন টসিক বিং অ্যানোমালি, তার সাথে আমাদের হাইপোপ্লাস্টিক আর্চ রয়েছে। সো সেখানে আমাদের খালি টসিক বিং অ্যানোমালিটা কারেক্ট করলে হবে নাকি তার সাথে এওটিক আর্চটাও রিপেয়ার করতে হবে, বা ধরুন কোনো একটা বড় ভিএসডি, উই হ্যাভ এ লার্জ ভিএসডি, in that project we want to see whether we can be that VSD should be repaired alone, or the aortic arch also needs some kind of intervention, because when we close the VSD, the real form of the co-operation of aorta might come into forefront. So co-operation of the aorta, by definition, it refers to narrowing of the aortic isthmus, but obviously this definition spans across much other segments as well. It can increase, it can span across the hypoplasty of the aortic arch and have other associated cardiovascular anomalies. And the term is also used to describe strictures of other segments of the thoracic or the abdominal aorta. Right. So the incidence is approximately about 36 per most common, or approximately 5 to 7% of the patients will see. In 64% of the patients, co-operation manifests as the dominant congenital heart disease soon after birth. Rest of the people, about 36%, manifests at an older age. So about 2/3 presents at birth or soon after birth, and about 36% manifests at an older age. So it is 1.3 to 1.7 times more likely in males. And in the prenatal series, co-operation consists of 3 to 10% of all prenatal diagnosis of congenital heart disease. So no single etiologic cause has been proven, but there is a complex interplay between the genetic, environmental, and the hemodynamic factors. The mainstay of the main therapy, the main genetic theory which goes in, or the physiological theory which goes in, is there is an abnormal flow distribution during the fetal life with decreased aortic flow. Normally, the aortic isthmus, or the transverse part of the aorta, receives only about 10% of the combined cardiac output during fetal life. So that is one of the most common predisposing factors where there might be hypoplasia of the aortic arch. And more than 71% of the case of aortic atresia also have co-operation. Now, what are the role of genetic factors? There are some very well-known genetic associations, like 12% of patients with Turner syndrome have co-operation, and obviously in chromosome 22q11 microdeletion, patients with co-operation, they may present with co-operation or even with interruption of the aorta, interruption of the aortic arch. So these are some features where they might be pedal edema, there might be wide space nipple. This is a typical feature of the velocardiofacial syndrome or 22q11 deletion, and this is the exact place in the chromosome where it can be deleted. Morphology and the classification. The aortic arch is basically divided into 3 segments. So the anatomic criteria for defining arch hypoplasia is a proximal aortic arch of 60% of the aortic diameter, distal aortic arch of 50% of the aortic diameter, and the isthmic narrowing of 40%. So the commonly used echocardiograph definition determining the transverse hypoplasia in neonates is if an internal diameter less than 1 millimeter for every 1 kilo body weight. For example, if the body weight is 3 kilos, then the internal diameter should be at least of 3 millimeters. And then diameter or z-score of less than 2 standard deviations, the norm of population's mean. And this is the general definition of, you can see this is the ascending aorta, right? The adjacent part across the aortic valve. And after the first branch, this is a commonly drawn left-sided aortic left subclavian artery is the distal arch, and the part beyond the left subclavian artery, including the isthmus, is the descending thoracic aorta. And this part, this immediate part which is adjacent to the left subclavian artery, known as the isthmus. So coarctation usually results from narrowing of the aortic isthmus at its junction with the proximal descending aorta at the insertion of the arterial duct. That is the juxtaductal coarctation. One of the theories is that the ductal tissue is incorporated within the isthmus, and whenever the duct actually closes, that portion might be chimped and there might be a coarctation of aorta. But the anatomic spectrum is quite wide, and there may be different morphologic patterns which can be distinguished based on the age of the diagnosis. Whether it is before birth, early infancy, or older children and adults, they have different kind of segments. This is a brief part with a brief video on how the aortic arch actually develops. As you can know, there's a mnemonic. There's a 1, 2, 5, 1, 2, 3, 4, 5, 6. There are 6 aortic arches, and there is a 2. By definition, there are 2 aortic arches which develop bilaterally. So I found that this cartoon might be helpful to you all, especially the postgraduates, where, as you all know, axopmochi, 1, 2, 5 arches usually disappear. 3, 4, and 6, third, fourth, and sixth arches actually make up the final aortic arch. So in the fetus and the infant, what happens is the angle between the ascending aorta and the transverse arch is acute. Between the ascending aorta and the transverse arch is acute. This is the angulation which I have tried to show you. The distal transverse arch between the left common carotid and the left subclavian artery is often elongated and hypoplastic, which is known as the tubular hypoplasia, and the aortic isthmus is diffusely hypoplastic. However, the arterial duct is almost always widely patent, and whenever that closes, in gradual development coarctation is reported during closure of the period, and histologic studies have proven that they demonstrate ductal tissue circumferentially surrounding the isthmus. Although the stenotic site is typically located at the distal isthmus, other locations or multiple sites can be found, especially opposite or proximal to the origin of the left subclavian artery or the other brachiocephalic artery. And in older children and adults, aortic arch hyperplasia is less common. Coarctation segment is usually discrete, and collateral arteries bypassing the coarctation are common. The collaterals usually form from the increased flow through the internal mammary, intercostals, and scapular arteries. Regardless of the age of the diagnosis, the coarctation segment is characterized by luminal narrowing due to thickening of the intima and the media, and hypoplasia and tortuosity. The endoluminal protrusion of the intimal medial region shelf is typically circumferential, especially in adult varieties, and often more prominent there is a posterior and lateral wall of the aortic isthmus. The length of the stenotic segment varies from discrete. In a discrete coarctation, what do we mean by discrete coarctation? The length usually stays between 2 to 3 millimeters, to a long segment coarctation where the length might vary between 7 to 20 millimeters, and the proximal descending aorta immediately past the coarctation often exhibits the post-stenotic dilatation, giving rise to the typical 3 configuration, figure of 3 configuration, or inverted E appearance on the anteroposterior view, PA view of
So I think your internet is unstable. We are losing your voice frequently. They disconnected. Sorry, sir. We lost you for a moment.
Okay. Sorry for that. Can you hear me now? Really, coarctation of aorta can involve the other segments of the aorta as well. For example, if it involves the abdominal coarctation, the involved segment is often long, the aortic media is markedly thickened, with involvement of the renal and mesenteric vessels, and involvement of the thoracic and abdominal aorta and branches have been reported in Takashu's disease, supravalvular aortic stenosis like Williams, familial aortic stenosis, and sporadic supravalvular aortic stenosis, and the middle aortic syndrome. And what do you mean by pseudocoaptation? There is deformity of the aortic isthmus with tortuosity without luminal narrowing. So this is a typical finding which might be found in CT scan on CT and other imaging. The isthmus and part of the DT are deformed, most frequently in the shape of the digit 3, but there is no internal luminal narrowing. Like this is a CT scan, this is a sagittal view, and this is a three-dimensional constructed one. And internally, the diameter of the caliber of the isthmus is not narrowed, and the blood flow is not obstructed. And incidentally, this pseudocoaptation may be seen even in the abdominal aorta, as seen on this particular CT scan. The pathophysiology, I won't go into that one. I'll show you some more pictures so that before going on to my next, this is the imaging. The key elements are how we diagnose the one. I think I'll put my talk short of the proper one so that I can discuss more on my presentation. Should I go on to the presentation about the case which we did this morning?
If you think that would be more appropriate, you can do, sir.
Fine. I'll just stop with this particular view, which I wanted the postgraduates to learn. This is a coaptation of the severe transverse aortic hyperplasia. There's a suprasternal view, elongated hypoplastic arch. This is the one which we were mostly concerned of, that whether the arch needs to be repaired at the same time with other intracardiac anomalies, or the arch can be left below. This is a typical example of an adult coaptation with the coaptation ridge from the posterolateral aspect. This is a typical arch of a neonate, whereby with transverse aortic hyperplasia, the coaptation was a VSD or other, and the typical of the PDA, where the PDA might be supplying the descending thoracic aorta, or both might be supplying the descending thoracic aorta. Fine. Okay, open the login. So I'll log in from here. I'll log in from another computer. Just give me 1 minute time. I'll log in from another computer for our listing. May I request you just to promote me as a panelist for this thing when I log in from another computer.
Amitabh, good afternoon from Dhaka.
Good afternoon, sir.
How are you?
Yeah, fine.
You are my proud actor of pediatric cardiology, like Amitabh Bachchan, and you are Amitabh Chattopadhyay, my proud actor of pediatric cardiology. Thank you very much for your presentation.
Thank you.
Amitabh.
Sir, I have logged in from another unit with the name of same name as Amitabh Chattopadhyay. Can I be promoted to a panelist?
Yeah, Amitabh.
Yes, sir. বলুন কেমন আছেন?
হ্যাঁ, খুব ভালো আছি আপনার আশীর্বাদে। আপনারা কেমন আছেন?
আমরা ভালো আছি দাদা। We are doing well. We are trying to recover from the pandemic as much as possible. Our whole team is here, and today we have done LPS stenting, left pulmonary artery stenting this morning.
Yeah. So
and
nice
I'll be demonstrating that one.
Nice to see you as well as hear from you. This wonderful presentation. We are really benefited from your elaborative presentation regarding coarctation of aorta. And
I wanted to, sir, bolun.
আপনি কি বলতে চেয়েছিলেন বলুন।
I wanted to impress on the hypoplasty of the arch, which is often missed or which is not often missed. That is the reason I did not show any interventions in my presentation. I just wanted to reinforce on the echocardiographic diagnosis.
But we are waiting for some kind of intervention, like you can show.
Right, I'll show you.
So regarding your theoretical aspect, how a pediatric cardiologist can assess whether which patient will go for surgery and which patient will go for intervention, either balloon angioplasty or stenting, whether covered stent or simple VR stent. So what are the crucial points to assess for the selection of these two modalities of treatment?
For example, we follow the protocol, like if there is a neonate with a severe dysfunction, ideally speaking, unless there is a severe dysfunction, neonatal coarctations do well with surgery. because the whole segment is incised or rather excised, and there's an end-to-end anastomosis. But there are some cases which we have presenting with severe dysfunction, and surgery in those children might be very dangerous or difficult for them to come out. In those cases, if the child is presenting with severe dysfunction, we usually go for balloon dilatation just to tide over the crisis. And thereafter, when the child recovers, and if there is re-stenosis at that point, they go for the surgery and end-to-end anastomosis. If it is an infant or an older child, then probably the first choice would be balloon dilatation. Nowadays, the only thing remains is the stenting. Now, usually before, in the era, say about 5 years back, we used to take our patients with caution for stenting, like only people who are qualifying more than 15 kilos, they would accommodate our stents. But nowadays, we have done stentings below 15 kilos as well. From 10 to 15 kilos, we have done stenting because we have now some growth stents or redilatable stents. That is Cook's formula stent, which can be redilated to at least 1.8 times to 2 times its diameter. Hence, in those cases, we can put for example, instead of doing a primary balloon, we can get rid of the whole disease process by putting a stent across the coarctus segment whereby there is a discrete coarctation. So we put a Cook stents, and if needed, they can be dilated later on to an adult size. For example, if I put a 9 millimeter, depending on the descending thoracic aorta diameter as 9 millimeters, if I put a 9 millimeter stent, that stent can be approximately dilated to at least 16 to 18 millimeters in later childhood or in early adulthood, if the situation demands so. So if an adult person comes to us, our primary dictum would be to go for a stenting. If an older child comes to us, we'll go for either a balloon or a stenting. Except in infants, in small infants and in neonates, the first choice will be surgery, because in those cases it has been seen historically and through different papers that the results of surgery are much better than balloon dilatation, because there's a high chance of recoarctation on simple balloon dilatation. And choice of stents, we usually use Andra stents nowadays because the CP stents are too costly. And in our country, the cost does matter, because a CP stent with a beep balloon will be approximately 3.5 lakhs to 4 lakhs INR, whereas an Andra stent will be approximately around 2 to 2.5 lakhs. So it is slightly cheaper and people can afford that one. It gives a very good radial strength and it can last for a longer time with a fewer incidence of neointimal proliferation. Self-expanding stents we usually do not use. I remember in one situation we were bound to use in one case in DSMU, because that patient was almost dying with severe heart failure. It was a Takashio's disease with the coarctation of aorta spanning from the thoracic aorta to the almost the abdominal aorta, but the end result was very good and the patient could come out of the ventilator.
So, sir, you are going to log out from this computer and log in from another one? Okay.
Yes.
Okay.
PPT. Oh, the PPT.
Okay, I think, sir, we got you on the other one.
Okay. Just before that, sir. Yes, sir. Just before I log in just allow me, because my colleague Dr. Rishika will present about the case. It's a 2-minute presentation and we'll be presenting the synopsis of the case. It's a 2-minute presentation about the case. She'll be telling about LPS stenting. So I'll just share my screen for a moment. I'll introduce Dr. Rishika. She is our third-year fellow, final year fellow. She'll be going for the examination. And this is a 2-minute presentation regarding the case which you have done this morning. So over to Rishika while I log in from the other unit. Can you see Dr. Rishika? I think.
No, her voice is not clear.
audible now?
Yeah, you are audible.
So we have good afternoon, everyone. Today I'm going to present the synopsis of the case we did today morning. This was a 2-year, 2-month-old female baby, a typical Digeorge facies. However, we did not go for any genetic testing as for financial constraints. She was diagnosed to have a cyanotic heart disease when she had first gone to a doctor concerning her anorectal malformation and was diagnosed to have tetralogy of Fallot. She underwent a total repair, that is VSD closure with transannular patch with LP plastic on December 12, 2020. Pre-op, she had an echo which found it was a top with a severe LP origin stenosis. Post that, the child was okay. Also, she underwent a first colostomy on 27th of May 2021 after her Fallot's tetralogy was corrected. On follow-up visit, we found that this was the X-ray of the chest, which had a clear differential vascularity with very little vascularity on the left side and good vascularity on the right side. Of her follow-up echocardiogram had showed a VSD patch in situ. There was no residual. However, there was a striking LP origin stenosis. This is the fourth view, which had a dilated RARV. Yet a mild TR was present. There was an RVOT gradient of around 30. And the branch pulmonary arteries, the cross branch pulmonary arteries, which open into a different planes, and LP had a severe origin stenosis measuring around 3.2 mm and distal LP measured around 9.5 mm. We did a CT angiogram for this child and we could see a good right-sided branch pulmonary artery, and LP had a severe origin stenosis. These are the axial cut sections and this is the sagittal cut section, which showed that the LP was severely origin stenosis. So it was decided to stent the LP.
So now I'll be going to the presentation. We have done the case already. And this is a case in the box. We'll be showing as a case in the box. I will take approximately 25 minutes. We have measured the time. We have time. Can you hear me now, sirs?
Yes, you are audible.
Can you hear me and see my screen, sir?
Yes, we can see your screen.
Narayana Super Specialty Hospital, and it is very nice to meet you all at Dhaka, Bangladesh, at the National Heart Foundation and all of our hospitals at Dhaka and all our friends. We are meeting after a long time post the COVID era, and I hope that you all are doing well and all the general people in both the countries are doing their best. This morning we have gathered for a contemplated left pulmonary artery stenting on a small child, Prarthana, who is 2 years females, and she underwent a top repair, as has already been depicted by our friend Dr. Rishika in the PowerPoint presentation. And this morning we are planning to do an LPS stenting. The background is that she was operated in December 2000 for a tetralogy Fallot repair and was detected to have an LPS stenosis in the month of about April 2021. Thereafter, we had a CT scan done, and from the different views, we discovered that there was a dilatation of the main pulmonary artery along with the patch, and there was a stenosis at the LP origin, which was a discrete stenosis with the post-stenotic dilatation of around 9.3 millimeters on the left pulmonary artery.
Sir, sir? Are you audible?
Yes, you are audible.
Okay, we'll just play the whole video. It takes 25 minutes.
So we are planning to put a Cook's formula stent there, and I'll detail the descriptions of the procedure as we go on. So the first step is an RV angiogram. So in our team today, I am flanked by my colleagues, Dr. Sanjeevan, Dr. Joyita, and Dr. Madhurima. Dr. Parijat is a helm of the affairs at the anesthetics side. In our technical team and nursing team, we have Seema Meeta and Urmila, and our technician team, we have Shubhajit and Srinjan. And we have the whole team from Cubex who are transmitting this program along with Abbott to your center. We hope to do a good job. And in this our cath lab, maybe you can just show the surrounding of our cath lab a bit. You can just show the surrounding of our cath lab. This is a dedicated pediatric cath lab, and we do approximately, the pre-COVID era, we used to do approximately 650 to 700 cases per year. Obviously, during the COVID season, we dropped the numbers, and this year we are gradually coping up. In the last month, we have touched about 50 cases in a month. So this is the RV pressures, which is about 52 with a mean of 11, I mean, industrial of 11, and against a systemic pressure of 99.58 with a mean of 76. So it's almost half to two-thirds systemic. So let us do the angiogram first. We'll be doing the angiogram in our preferable views, which is a deep, steep ileocranial. And if we do not see much of the LPA origin, which we are trying to see in this case, then we might take some other views. We usually take an ileocaudal or a steep lateral or a 90 degrees lateral. So these are three usual views which take: steep ileocranial, ileocaudal, and if nothing is visualized, then we might take a simple lateral as well. Stop.
Stop.
एक कारण हम बात करो. Dear friends, now that we have done the angiograms, and you can see the pigtail is in the main pulmonary artery, which was seen to be dilated from the RV angiogram. But from the RV angiogram, we have seen an outline of the branch pulmonary arteries, but you couldn't see the origin of the left pulmonary artery, which has been covered by the dilated MPA. Now, to find out the origin of the left pulmonary artery, we have to take some special views. So we have done that one. So number one angiogram, which we have done after with a pigtail inside the main pulmonary artery at the junction of the MPA, RP, and LPA. So this is a view which we have taken at LAO at LAO 35 and cranial caudal 40. So this view has been taken. This is a normal view which we take for the branch pulmonary arteries. And here you can see the right pulmonary artery. Actually, the right and left pulmonary arteries crossing each other, which is known as the crossed branch pulmonary arteries. The right pulmonary artery is quite dilated and filling of the RPA, I mean right lung. The left pulmonary artery you can see actually is arising from the right side, and it is very narrow, and there is left lung is getting filled, but the quantity of filling of the left lung is much less compared to the right, which justifies our action that today we are going to do a LPA stenting. One more thing which could have been done is a ventilation perfusion scan, which we have not done in this case because we are confident that the CT scan and the physiological nature of the constriction itself justifies that we have to do a LPA stenting. The next view we have taken is LAO 81 and a cranial 5 degrees, which is a very steep ileocranial, almost equivalent to a 90-degree lateral. Here we have a picture similar to the one which we have already shown in the CT scan. You can see the right pulmonary artery which is dilated, which is facing downstairs, and you can see from the upstairs, from the above of the image, you can see that the second stapler pin is just showing the origin of the left pulmonary artery, which at origin measures probably roughly around 3 millimeters, but down as soon as it takes off, is severely stenosed and is giving a picture that there is a very small artery which is arising from the main pulmonary artery. Next view, please. So these are the two views which we have taken, which have specifically guided us to give the LPA picture. And you can see that the main pulmonary artery is dilated, which is because of the transannular patch. And also in this view, you can see one more thing. There is severe pulmonary regurgitation in this 81.5 view. There is severe pulmonary regurgitation, which is reflected in the hemodynamic monitor. As you can see, the systemic pressure is 88/46/63, and the PA pressure is 48/0 with a mean of 22. That means a very low diastolic is due to the severe pulmonary regurgitation, And the pressure, systolic pressure of 48 is an augmented view actually, because the real PA pressure would be much less. This is because of the severe pulmonary regurgitation, which is causing the right ventricular ejection to be much, much higher than expected. So the actual PA pressure, if the pulmonary regurgitation would have been subtracted, would have been in the range of say 30 to 35. So the next step we are going to do is we have to now approach the pulmonary artery, left pulmonary artery origin, which is the most difficult part of the procedure. And my colleagues will do that one with the help of special catheters. Here we are choosing either a right pulmonary, either a RCA catheter or an MPA catheter, or sometimes we might have to take a TIC catheter or some other specialist angle catheter, so that we can have the right left pulmonary artery to be engaged.
Now you are trying to cross the left pulmonary artery, main pulmonary artery and the left pulmonary artery junction, with the help of a Terumo O25 straight tip exchange length Terumo wire and a multipurpose catheter. So you have to keep on repeatedly trying, because the main difficulty here is that the main pulmonary artery is hugely dilated and the left pulmonary artery is just a small orifice, which is extremely stenosed, and we have to find out the orifice. Luckily, Joyita and Sanjeevan has crossed it without much problem within the first 3 minutes. And now after Joyita has crossed that one, the orifice, she'll be trying to park the wire in the deepest corner so as to give us an extra leverage so that we can pass the catheter over it. Am I audible, sir?
Hello, Amitabh.
Yes, sir. Am I audible?
Yeah, you are audible and visible also. Thank you.
We are crossing and we are parking the wire in the deepest distance. So Sanjeevan has come, he has joined me. Now we are parking the catheter in the deepest part of the left pulmonary artery, in the left lower branch.
Amitabh, which we could appreciate, that is your case has a dual stenosis, pulmonary valvular stenosis as well as LP stenosis, is it not?
Sir, no, sir, this is a post-operative tetralogy fellow. Tetralogy fellow. So this child had left pulmonary artery stenosis,
pulmonary
which was operated on, patch augmentation was done, but there is severe stenosis recurrent. So now we are going to stent it.
Pulmonary regurgitation is there, okay. What is the gradient across the LPA as well as the MPA?
So it will come, sir. It will come here. We have shown the pressure gradients.
152
Distal LP pressure near around 11. So systolic pressure gradient are
আরবি দেখালে একটা এলবি দেখালো না এরপরে আবার এলবি এর মধ্যে গ্রেডিয়েন্ট Oh,
Sir, can you hear me?
yeah, you are here.
Yeah, so basically the LPA pressure was around 50 systolic.
Yeah.
And if you see the distal LPA pressure,
So as you can see here,
Okay,
have,
go on.
systolic was around 11, 12.
Indian-
So there was a
Indian, can you show
gradient
the
of
crossing?
approximately 40 millimeter of mercury. And as you
So
can
Sanjeevan and
appreciate,
Jacob
there is no
crossed the
pulsatile flow in the LPA.
junction of the left pulmonary artery,
It was a
and now
severely
the catheter
obstructed LPA.
is in the distal.
Yeah,
Can you see the
in the
distal
wire
LPA
now.
pressure?
yeah.
Go here.
Did you perform any angiogram in AP view?
Yeah, sir.
Is 7, whereas the diastolic
Can
pressure
we
was
see?
0 in the main pulmonary artery.
Yeah, main pulmonary artery
So let us
pressure
now
was zero
cross over
because
and
this
exchange the
particular
wire,
child,
exchange
the
the
RVOT was
catheter.
augmented with a tap, that is transannular patch, and there was no pulmonary valve. So there was a severe pulmonary artery regurgitation, the end result of which the PA diastolic pressure was very low, 0.
Yeah. But for during the initial correction of tetralogy of Fallot, was it missed this LPA stenosis or they have done LPA plasty and post LPA plasty re-stenosis? Is it which one?
Yeah, sir, because this is very natural, because the surgical plasty of the branch pulmonary artery,
Yeah.
usually the result is very bad.
Yeah.
Majority of the time it will end up in a restenosis.
Yeah. Now, what is the narrowest part of the LPA as well as what are the size of?
So we got a CT scan done. In that particular CT scan, the origin was measuring approximately 2 millimeter, and the distal LPA was measured to be 9 millimeter.
Yeah. So what are the size of stent you are selecting and which kind of
So,
stent?
Focus on the
if
wire
you
now.
see it carefully, so we will just play the video. Initially,
There is an ultra stiff
we
wire
put a stent
which we
diameter
will
of
exchange.
around 9 millimeter, and the stenos segment we measured around 12 millimeter. So we
And-
thought take up a stent of approximately 9 into 20 millimeter, so that we can nicely cover the whole of the stenos length. Okay.
Yeah. Is it
Request you to
the-
kindly see the sequence, all the NGOs and all. So right now, can you play here?
is this stent redilatable or not?
Yeah, so we are using a Cook formula stent. So as you all know, Cook formula stent can be dilated up to 200% of its original diameter. So if we can take a 9 millimeter stent, it will be it can be post dilated up to 18, which is
Okay.
enough for adult also. So that
What are the size of sheath you are selecting for it?
So yeah,
deployment?
so for a 9 into 20 millimeter Cook formula stent, you will require a 7 French sheath.
Okay.
We thought we'll go ahead with a 7 French PDA delivery system of Life Tech.
Okay.
Okay. But we had a significant difficulty in taking up the sheath. Okay, advancing the sheath. So we are. So
Good afternoon and welcome
yeah,
back
just
to
listen
this
to
case.
this.
So what we did was basically, we have until now we have shown you that we have crossed through the LPA junction, MPA LPA junction, and we had kept our wire, that is the thermo wire, 025 J-tip extended thermo wire deep inside the left lower branch of the left pulmonary artery. Now after that, the procedure which we followed was, first of all, we slid our MP catheter over the wire into the deepest portion, and thereafter we exchange the thermo wire with the ultra stiff wire.
Sir, can
That
you
is the
all
one
see
which
and
we showed. That's
listen?
the.
Are we
Can
audible?
you show the fluoro, please?
Yeah, you are audible.
And you
We
can
can
show the
hear
stroke fluoro as well.
Amitabh.
Yeah,
Ultra
that's
stiff
fine.
wire,
You
which
just
is the
continue hearing
white
that.
colored.
Okay, everything
one.
is explained.
It's a little bit stiffer than the super stiff wire which we use in our regular ASDs or PDA device closures. So this gives us a firm anchorage so that our delivery system can move over it. But in this case, as you can see in the consecutive fluoroscopic recordings, that our delivery system, which was a 7 French LifeTech PDA device delivery system, could not be encroached past the severe stenosis at the LPA origin. You can see we have tried many times, but what was happening is, as I was telling in previously, the wire was flipping back, which means that even with the ultra stiff wire, it was not giving us enough of a support, and it was not allowing the sheath to get past the severe origin stenosis. So we tried several times consecutively, like we exchanged the wire and we tried to move over multipurpose catheter, slide the delivery system over a multipurpose catheter, which did not work. Then what we did was we decided, Joyita told that probably we can balloon dilate the origin. So similarly, we need a very stiff balloon, but at the same time, since we have an ultra stiff wire, which is 035, hence there are very less balloons which can be moved over it. Hence what we did was we exchanged the ultra stiff wire with a multipurpose catheter. You can see how stenosed the mouth is. We exchanged again the multipurpose and the ultra stiff wire in lieu of a coronary wire. Then we took a 4 by 12 millimeters peripheral balloon, coronary balloon, and dilated it 4 times. Thus we thought that we have bombarded the whole pathway from the left pulmonary artery origin a little bit to and fro. And then we tried to slide over the delivery system again with the help of the obturator. But to our surprise, this time also the delivery system could not be sent past the severe origin stenosis. Hence we again exchanged the wire along with the catheter, and this time we took a much more stronger balloon, a Mustang balloon, 5 into 40 millimeters Mustang balloon, and we dilated the whole origin a little bit to and fro, so that this time our catheter, our delivery system can go past. This is the Mustang balloon dilatation. As you can see, we have balloon dilated the whole segment, and to our satisfactory response. So this time what we did was we again tried to cross over the severe stenosis, but again to our surprise, it was so severely stenosed that this time also it was not allowing, along with the obturator, the delivery system to go past. The wire, that the stiff wire, ultra stiff wire, was again flipping back. Then we decided to change the strategy.
Sir, may I ask you at this stage, like what would be your opinion and what would you like to do at this stage that we are being unable? It's extremely difficult to pass the delivery sheet across the stenos segment. Though we have an access, we haven't lost our access even for a while. We had crossed over to the left of the artery. We have maintained our access with the help of wires, but we are being unable to cross the main stenosis, the LP origin stenosis, and our delivery sheet is being unable. We are unable to pass the delivery sheet. So what would you prefer? May I ask the audience and the respected chairpersons, what would you prefer at this stage? What would you like to?
Yeah, Amitabh, can you hear?
Yes, sir.
Actually, the tips and tricks to cross the stenotically part of the pulmonary artery, we like to hear from you, number one. Number two, pre-dilate, which you could appreciate. There is pre-dilatation with stiffer balloon or cutting edge balloon or peripheral balloon is necessary for easy negotiation of the sheath.
Yes, sir. Exactly the same thing we also thought. We dilated the origin first of all with a 4 into 12 millimeter coronary balloon. That is a not very stiff balloon. After that, we took a Mustang. As you all know, Mustang is a very
Mustang,
Yeah, so Mustang, with the Mustang, you can go up to a pressure of around 18 millimeter.
The
burst pressure. So we fully dilated the origin of the LPA with the Mustang 5 into 40 millimeter.
One question to you, actually LPA has got an acute angulation across the left pulmonary, left principal bronchus. And,
exactly, sir.
And that acute angle, you are going across and going to the lower part.
Exactly, sir. It
if you negotiate to the
There were basically two problems. First of all,
upper branch of the pulmonary artery,
the normal
first
anatomy was
branch.
distorted because of the surgery. That's why the LPA was coming off at a very
Steep angle.
Steep
very
angle.
Extremely steep angle.
and definitely the LPA origin was severely stenosed. Despite of dilating it with all the possible stiff balloons also, it was not giving the pathway to pass the sheath. That was the main problem we have faced.
As you can appreciate, it's a 180-degree turn, absolute 180-degree turn. So it is very difficult to negotiate. What will happen is, as I have described in the narration, that what happens if the wire is not strong enough, as we exchange, as we advance the delivery sheet, it might just flip off. So we have to be extremely careful in this one. So we followed the book teachings, like the steps. We tried to
So
dial into the
we'll
balloon
just,
as well.
we'll just play the video. What we exactly did, you can see in the video. We'll continue the video.
Strategy was, since this, as you can see, with much efforts, with much time and much patience, this was not allowing the delivery system. Now there might be a question that whether the advancing the delivery system was at all required, whether the stent could be advanced over the wire, especially keeping the, for example, say keeping the stiff wire there, and the delivery system would be just up to the point where the stenosis starts, whether we could move the stent. But to our experience, the kind of stent which we are using, or rather any stent, whether it is a pre-mounted or a balloon crimped stent, what might happen is, in such a severe stenosis, if we try to advance the balloon and the stent system, either crimped or pre-mounted over the wire without the guarding of a delivery system, then the stent might get blocked at the origin. And it has happened before that the balloon might get advanced alone and the stent might be left behind. And if this happens, then we call for an emergency, because then the stent will be just floating inside the main pulmonary artery without even advancing to the left pulmonary artery. So this is a very delicate balancing act, and we avoided such a proposition. Hence, the next step would have been that we change our strategy, and since this sheath was not at all advancing to a safe distance where we could take the stent inside the housing, we changed the strategy to change the stent overall. So previously, our choice of stent was a Cook 9x20 stent, that is 9 millimeters of diameter and the length of 20 millimeters, because there was on the CT scan, the length of the stenosis itself, as you can see on the angiogram, the length of the stenosis itself was around 12 millimeters. So that is the reason we were choosing about 20, just to center and balance the stent just at the middle of the stenotic part. So now, since the sheath was not advanceable at all, we changed the stiff wire in lieu of a coronary wire, which was which was ultra stiff coronary wire. Grand Slam coronary wire 014, and over which was parked again in the same position. Over it, we had advanced a 7 French guiding catheter, which is here, the 7 French guiding catheter. So this went through the PDA device delivery system over the coronary wire, and this one passed over the stenosis easily. Though I won't say easily, because Sanjeevan had to manipulate to some extent. So this particular catheter saved the day. So we could advance this catheter past the stenosis, and ultimately we reached our destination. The angiogram, please. Can you show the fluoro, that part? As you can see, this is the delivery system is standing at the junction of the MP and the LPA. The 7 French catheter, guiding catheter, has passed the stenosis over the coronary wire, and now we were in a safe position. Now the ultimate, this was the penultimate step. Now the ultimate step, next fluoro, please. Our choice of stent was 7 into 16 millimeters Cook's formula stent, which would move over the 014 coronary wire. So there are 3 series of these stents, 014, 018, and 035. Since the 035 system, we had the 035 system of collection of stents, but since the 035 system was not applicable in this case, hence we moved on to the 014. So this wire, this particular stent moves over a coronary wire 014 system, and we delivered the stent over the coronary wire through the 7 French delivery system. Now the next angio, please. You can see here also there was some amount of difficulty, and it required enormous amount of coordination between the 3 and 4 operators. So what we did was, The sheath, there is a delivery system, stood at the junction of the MP and the LPA. The delivery system, the second delivery system, that is the 7 French delivery and 7 French guiding catheter, went just past, and the stent was advanced halfway across the tip of the catheter. Under this condition, with enormous amount of control, the whole system was pulled back inch by inch, millimeter by millimeter, and we, by side, we had to do angiograms through the side arms, and we saw to place the stent exactly in the midway of the stenosis, so that some part of it, approximately about 3 to 4 millimeters, was hanging in the LPA, and about 3 to 4 millimeters was hanging in the MPA. So the main part, that the stenos part, was spanned by the middle part of the stent, which we confirmed number of times from different angles through hand injections. Now the 7 into 16 millimeter stent, which has been placed exactly at the center, was dilated up to 10, I think. 10 atmospheres, yes. We dilated up to 10 atmospheres, and thereafter, you can see the dilatation of the stent now. Next one. Yes, this one. This was, and we were assured to see that you can see the beauty of the stent. The stent dilates at both the tips first, and the waist was dilated the last, so that this gives a firm grip. And there was dilatation. There are plenty of stents who dilate from one end, like the distal end, some from the proximal end. This one dilated from both the ends, and it gives us a firm reassurance that the central part has been caught in the stenosis, main stenosis, and there was no chance of the stent being dislodged. So hence we could have redilated the stent to another 8 or 9 millimeters, but on second thoughts, we did not do that, because slipping another balloon through this very delicate stent would have been slightly difficult for us, because we have already come across almost 2 hours, and it was extremely difficult to negotiate the stenosis. So we are quite happy, because the distal diameter of the distal left pulmonary artery was 9 millimeters. So ideally speaking, we could have dilated up to, say, at least 9 millimeters. But I think 7 into 16 has done a very marvelous job, and the 7 millimeter diameter has put out adequate amount of QP to the left lung. As you can see, this was an angiogram hand injection through the delivery system itself, and hereafter we decided that to take a pigtail wire through this one. I'll describe the hemodynamics a little bit later. We have taken a pigtail catheter through the delivery system, and here in the ileocranial view, you can see that there has been good arborization and good amount of QP distribution to both the lungs, almost equal. And here we have taken the pullback here as well, and the RV pressures have come down. As you can see on the hemodynamic monitor, there's a systemic pressure is 111/59 with a mean of 79, and the RV pressure, our pigtail is right inside the MPA-RV junction. Can you show fluoro? Yep. As you can see, it is just inside the MPA, and the main pulmonary pressure now is 4308, which has come down significantly. Initially, to start with, the systemic pressure was 90, systolic pressure was 90, with the RV pressure of 53, I think 54. And now, where the systemic pressure has gone up, 111/59 over a mean of 80, the RV pressure is 45/0 and 9, mean of 9. I think it has given a good result. Now the question is, what will happen in the future? So that this particular child, for the time being, has been saved from the LPA stenosis, and there will be equal LP and equal, amount of flow to both the lungs. In future, for example, she requires a pulmonary valve replacement because of the RARV dilatation from the severe PR. In that case, we have left enough of a space in the main pulmonary artery, and we have not kept the stent hanging in the main pulmonary artery, which might have interfered with the valve implantation. So anyway, down the way, maybe 10 years down the lane, she might require a pulmonary valve replacement, which probably this stent won't interfere in the placement of a pulmonary valve, because in that particular case, obviously, we can redilate the stent if required, but I don't think it will be required at all. And if a pulmonary valve replacement is required, then we have left enough of a room and space to park the wires and the stiff wires in that case, and enough of a room and space to house the pulmonary valve in that case, because there is enough of a space in the main pulmonary artery. And we have shown it by angiogram as well. I think if at all the pulmonary valve replacement is required, we have made enough of a space, and we have kept enough of a space for that one. So now we have come out And I would like to thank each and everyone who was present in this cath lab, our anesthetist, our my colleagues, and all the cath lab team and the audiovisual team. Thank you all very much for this patient hearing. And we will go off air now. And obviously, since this was a very difficult procedure, so we decided that we'll start in the day. As per our practice, all the difficult procedures we try to do as early as possible, because God forbid, if there are any emergencies, our surgeon friends might have some time. Rather than rushing in at the dead hour of the night, we'd like to do all the dangerous procedures, very difficult procedures, which was indeed a very difficult procedure in the early hours of the morning, so that if anything is required, then we can rush into the emergency surgery. Luckily, nothing emergency happened in this case, which could have happened, because the emergencies or the rather, dangers of these procedures are that if we are not attentive enough, we might have ruptured the RV, we might have injured the RA, or we might have injured the pulmonary artery, and we might have ruptured the junction. That is the very place which we are dilating. We might have ruptured that part if we are overzealously, we dilate that part. So though we might dilate the junction by about 200% in case of branch pulmonary arteries, but still we have to be very, very rational just to achieve that much of a result which is required. So luckily, the child has been maintaining blood pressure, did not require any blood transfusion, has a stable ABG and a blood pressure. The child we had on, as a precautionary measure, we had kept the child just on a touch of dose of 0.05 microgram per kilo per minute of adrenaline, is in sinus rhythm, and there is no pericardial effusion on echocardiogram. And hence, I think the child will be doing well. Thank you all very much for this opportunity to show our case. And I think this will give you enough of an impetus.
Thank you.
Thank
you very much.
And more cases, very nice cases, very interesting cases at your
Amitabh,
center.
thank you very
all
much.
Bye.
And thanks for the whole of your team. When the surgery was done for the child, intracardiac repair of top was done, tetralogy, Amitabh?
December 2020.
It was done in
20 December.
December, okay. There was any chance of transannular patch to be given during surgery for this kid?
Yeah, transannular patch has already been done.
Already done.
Transannular
Transannular
patch
up to LPA. That was also done. No.
LPA plastic
Yeah.
was
It was done along with the tap, transannular patch.
Okay. Okay. Thank you very much for nice presentation.
Thank you very much.
Thank you, Dr. Amitabh. It was an excellent presentation. And the thing you have shown that passing the guide catheter with pushing some dye and slowly, it was very nice and nice learning for us also. Thank you for extraordinary presentation.
Thank you, sir. Thank you very much for this case. It was a big learning experience, especially how you escalated and de-escalated your wires to accommodate and provide extra support to push your catheter. And you took your stent, and at the overall having patience, and this little 2-year-old kid also is very lucky that he could tolerate this second procedure after a big surgery just 8-10 months back.
Definitely. Thank you all.
Yes, sir. So thank you, sir. Thank you for your presence and giving time for our conference every year. Professor S.K. Razzak will give the closing remarks.
অমিতাভ, আমি একটা জিনিস স্মরণ করতে চাই, অনেক দুঃখ ভারাক্রান্ত হৃদয় নিয়ে আমি স্মরণ করছি। আমরা গত বছর কোভিড সময়, গত বছর সম্ভবত আমরা বিবিকে, বিশ্বজিৎ ব্যানার্জিকে হারিয়েছি। তা আপনি যদি ইন শর্ট একটু বলেন, কারণ সে আমার ফেলো পেডিয়াট্রিক কার্ডিও, আমি যখন ট্রেনিং করি 2000 মাদ্রাজ মেডিকেল মিশনে, আমরা একত্রে ছিলাম, অনেকদিন ছিলাম, আপনি সেখানে আসতেন। আমার খুব কষ্ট লাগছে যে আমি তার সাথে অনেকদিন কাটিয়েছি মাদ্রাজে ইন দ্য ইয়ার 2000। আমি এই সেশনটা আমি আমার সেই দাদা বিশ্বজিৎ ব্যানার্জিকে উৎসর্গ করতে চাই। আপনি যদি কিছু বলেন।
স্যার, আমার একটা স্পেশাল প্রেজেন্টেশন আছে। থ্যাংক ইউ ফর অ্যালাউইং মি 5 মিনিটস। আমি স্পেশাল প্রেজেন্টেশনটা আপনাদের কাছে দিচ্ছি। আমার মনে হয় তাতে আপনারা করতে পারবেন। জাস্ট লেট মি অ্যালাউ দিস ওয়ান। স্যার আমি এখান থেকে লগ আউট করছি স্যার। And tribute to him. স্যার আপনি কি দেখতে পাচ্ছেন আমার প্রেজেন্টেশনটা?
No, not yet.
Okay. Can you see it now?
Yes, yes, it is visible.
অডিও যাবে না স্যার, অডিও করা নাই,
Audio করুন।
শেষ অন করা নেই।
শেয়ার সাউন্ড করনি?
করে দাও শেয়ার সাউন্ড করে দাও। উপর থেকে রাখো, জুম ইন্ডেটের লেফট সাইডে উপরে একটা আছে, লেফট টপ লেফট।
We can hear the sound.
You can hear the sound, sir?
এটা
Yes.
No.
Just play the video. Just play the video.
স্যার স্যার এটা
Sorry.
নমস্কার, আমি ডক্টর বিশ্বজিৎ বন্দ্যোপাধ্যায়, হেড অফ দ্য ডিপার্টমেন্ট অফ পিরিয়ডিক কার্ডিওলজি, রবীন্দ্রনাথ ঠাকুর হসপিটাল, কলকাতা। কিছু বাচ্চার জন্মগত হৃদরোগ সমস্যা নিয়ে আমরা কিছু আলোচনা করব একটুক্ষণ।
So we have a video of this one.
তোমাকে ভালোবেসে আমার চিরকুল কলকাতা, তুমিও হেঁটে দেখো কলকাতা, তুমিও ভেবে দেখো কলকাতা, তুমিও হেঁটে দেখো কলকাতা, তুমিও ভেবে দেখো যাবে কি না যাবে আমার সাথে।
কলকাতার এই অবিস্মরণীয় জিনিসটা যেন আমরা সকলে তুলে ধরতে পারি। বিশ্বজিৎ স্মৃতি আমাদের কাছে আছে এবং আমরা সবসময় তার লেগাসি বহন করে চলেছি। ও ছিল কলকাতার মানে পিডিয়াট্রিক কার্ডিওলজির অন্যতম পথপ্রদর্শক এবং আমরা সবসময় ওকে মনে করি যাতে করে আমরা সেই উৎসাহে আরো বেশি কাজ করতে পারি। আজকে কলকাতায় সারা ভারতবর্ষের তুলনায় কলকাতার যে কটি সেন্টার আছে সবসময় আমরা সেই সেন্টারগুলির সাথে তুলনা করে আমরা অনেক দূর এগিয়েছি, অনেক দূর, গত 15-16 বছরে আমরা অনেক দূর এগিয়েছি এবং আশা করি আগামী দিনে আমরা সবাইকে আরো খুশি করতে পারবো, আমাদের দেশের মানুষকে এবং সমস্ত জাতিকে আমরা আমাদের প্রত্যেকের আরো বেশি করে আমরা উৎসাহ করে কাজ করতে পারবো। বিশ্বজিৎর উদ্দেশ্যে আমরা PCSA 2020-তে একটা আলাদা করে রুম করব, একটা আলাদা করে হল করব ওর নামে এবং আমরা চেষ্টা করছি যাতে করে ওর নামে আমরা একটা কোনো একটা পুরস্কার বা একটা লেকচার যাতে রাখতে পারি। ও আমাদের সাথেই আছে এন্ড আমরা আশা করব যে PCSA 2020-তে ওকে যেন আমরা পুরোপুরি ভাবে মানে শ্রদ্ধার্ঘ্য অর্পণ করতে পারি। RN টেগোরের যে ঘরে 2022-তে যে ঘরে ও বসতো সেই ঘরের বাইরেই ওর স্মৃতিতে একটা ছবি রাখা আছে, তাতে আমরা প্রত্যেকেই দেখতে পাই যে ও কিন্তু এখন ওই ঘরেই বসে আছে। এইটুকু জানা, আমি ওর নিজস্ব ক্লাসমেট, আমরা একসাথে প্রায় 20 বছর কাজ করেছি এবং সেই স্মৃতিটা যাওয়ার নয়, সেই জন্য আমার নিজেরও আরো অনেকখানি খারাপ লাগে। বস্তুত ও চলে যাওয়ার পর সেই ঘরটা আমরা কখনো ঢুকতে পারিনি। সো দ্যাট রুম ইজ স্টিল ব্ল্যাঙ্ক। সেই রুমটা কিন্তু এখনো রয়ে গেছে এবং আপনারা এলে দেখতে পাবেন যে ওই রুমটাকে আমরা সযত্নে যত্ন করে রেখেছি। চেন্নাইয়ের দিনগুলো এখনো মনে পড়ে, রাজেশ স্যারের সাথে আমরা ওইখানে একসাথে সময়ও কাটিয়েছি, আপনার সাথে ওখানে প্রথম দেখা হয়েছিল। সেই স্মৃতিগুলো এখনো জলজান্ত রয়েছে আমাদের মনে। আশা করি আমরা তার স্মৃতির জন্য সদ্ব্যবহার করতে পারবো এবং তার পুরো লেগেসিটাকে ক্যারি করতে পারবো।
আপনাদের এই উদ্যোগকে আমরা স্বাগত জানাই। আসলে সে ছিল পশ্চিমবঙ্গের পায়োনিয়ারদের সেই শুরু করেছে। আপনিও তার বন্ধু হয়ে আপনি তার পরবর্তীতে তার পথকে অনুসরণ করেছেন। আপনার ডিসাইপল এখন অনেক। তা আপনাদের এই উদ্যোগকে স্বাগত জানাই। সবাইকে ধন্যবাদ। থ্যাঙ্কস ফর দি প্যাশন শেয়ারিং।
Thank you very much.
Very much like Saudi. ওখান থেকে feedback.
Professor S.K. Rajak, sir. Dr. Lieutenant Colonel Mahmoud Nazmul Islam Bhuya, who will attend with online. And I'm requesting our honorable panelists to take seat in the dais. We have 6 presenters in this session. And each presenter will get 7 minutes for their presentation, and at the end of presentation, 3 presenters will get reward for their best performance. There is also an announcement that any person from the audience can ask any question, and best question from the person will get answer. That person will get answer. Get present. Okay. I'm requesting Associate Professor Umme Nasin Jake Madam to come to the dais. Okay. No. Professor Rajak, sir. With your permission, we are going to start our presentation. Okay. Our first presenter is Dr. Jasmine Hussain, Assistant Professor from National Heart Foundation.
Assalamu alaikum. Welcome to all. সবাইকে একদম পড়ন্ত বিকালের শুভেচ্ছা জানাচ্ছি। এই শেষ বিকালে আসলে সেশনটা খুব বোরিং, তারপরেও সবাইকে আমন্ত্রণ জানাচ্ছি আর কিছুক্ষণ কষ্ট করার জন্য। আমি ডক্টর জেসমিন হোসেন, আজকে আপনাদের সামনে দাঁড়িয়েছি কিছু কাজ নিয়ে। সেটা হচ্ছে আমরা প্রতিদিনই আমাদের প্র্যাকটিসে ডিওআরভি পেশেন্টের ডায়াগনোসিস করি। সো হোয়াট আর দ্য ইম্পর্টেন্ট অ্যানাটমিক ক্যারেক্টারিস্টিক্স and how we echocardiographic subtypes for surgical approach of double outlet right ventricle. Because why I choose this topics, because we know that DRV is a very complex congenital heart disease, and this is only one way to we can solve the disease by the surgery. So for the surgeon, it is very difficult to select an appropriate surgical approach for each variation. For that purpose, Pediatric Cardiac Center, Fuai Hospital, Beijing, they represent a very good echocardiographic classification which describes anatomic variation in more precise in terms. Nowadays, we are using DRV classification according to the Thoracic Surgeon and European Association of Cardiothoracic Surgery, like DRV VSD type, TOF type, transposition of greater is TGA type, or remote type. But in this classification, we cannot communicate with the surgeon how to the surgical approach. Here I use the interventricular communication is used the place of ventricular septal defect, because that in case of DRV, VSD is a different, there is a surgical and the morphological channel. I will describe it later. DRV surgery depends on 3 important anatomic characteristics. Among the anatomic characteristics, first one is relative position of the great arteries, and second one is relationship between the great arteries and the ventricular septal defect, and third one is the presence or absence of right ventricular outflow tract. Among the 3 principal anatomic factors, Fuai classified DRV as 8 subtypes. They are said that if the VSD is committed to the great arteries and the great arteries is a normal in relation with no RVOTO, this is called 1A, which is traditionally VSD type. If the VSD is committed to the great arteries with a normal great artery position with RVOT obstruction, traditionally we said that TOF type, they said that 1B. But when we traditionally said that DRV is a TOF type or VSD type, we cannot say to the surgeon, is VSD is committed or non-committed? Is the great arteries relationship is normal or abnormal? Same thing, 2A, 2B, VSD is non-committed, but great arteries relationship is normal and presence of RVOT or absent of RVOT. Type 3, this is remote type in traditional. Type 3, this is a committed VSD, but a malposed great vessel with the absent of right ventricular obstruction. This is simply as a TGA type. So in 4A, 4B, which is very difficult for the surgeon, and when we say that this is a non-committed VSD, malposed great vessel with the presence of right ventricular type obstruction, in this scenario, simply we think that we cannot do a biventricular repair, we can be a univentricular repair. So we have to explain it very clearly. I want to incorporate our patient and to Fuai classification. I took the patient from February 2017 to November 2021. 107 patient who was diagnosed double outlet right ventricle, and that patient first surgery at National Heart Foundation Hospital and Research Institute, and diagnosis was based on 2-dimensional echocardiography. In our case, the age distribution, minimum age is 2 months, median age is around 3 years. 61% were male. If I classified DRV in a traditional type, in our DRV classified biventricular repair, for the biventricular repair, classified the VSD type, TOF type, TGA type, and non-committed VSD type. I also took the single ventricle patient because we are not operated. All the patient is a biventricular. Some patient which is single ventricle physiology with a double outlet right ventricle, like a tricuspid atresia with DRV, or severely hypoplastic TV with a DRV, or hypoplastic MV, which is single ventricle physiology. You cannot do a biventricular repair. I took the patient to a single ventricle group. If I classified the interventricular communication, or traditionally we say that ventricular septal defect, right? What are the location? Mostly we found that there's a subaortic location, some are not subpulmonic, doubly committed, and some are non-committed. If I say that these interventricular communication classified according to commitment of the great arteries, mostly are the committed VSD, some are non-committed. I want to show you one video of this is parasternal long axis view. We saw that there is a aorta is 90% overriding. There is a aortomitral discontinuity, and here I want to say what is the in your view, what is the morphological VSD and what is the surgical VSD? VSD, we know that the communication between the LV and RV. So the morphological VSD is here. This is the communication from LV to RV. But if I close this VSD in the RV, our aorta remains in the RV. So it cannot be a VSD. Surgeon have to be incorporate the aorta to the LV. So surgeon need to be a channel from LV to aorta. In this view, you can see that there is a bilateral conus, which is upward anteriorly tilted with the great arteries. So VSD is the subaortic location, but that VSD is much more posterior to the aorta, and the great artery relationship is, we can see that in this slide, that the great artery relationship is the side by side. So this is a subaortic, but this is a remote VSD with a bilateral conus with a side-by-side great arteries. Sorry, this video is not showing. Yeah. So if I want to show you that great artery relationship in our cases, mostly 77% patient was a normally related great artery. Among the 9% was demalposed great artery, 10% was dextroposed but side by side great arteries, aorta in the right of PA. Right ventricular obstruction, mostly our patient was on tetralogy variety. So severe RVOT obstruction was more than 60%, and also 25% patient has a no RVOT obstruction. For the DRV echocardiography, we need to clarify very clearly aortic valve, atrioventricular valve morphology, because some atrioventricular valve morphology surgeon cannot do the biventricular repair, so we need carefully. So I also took for this. Here you can say that there is accessory mitral tissue causing the subpulmonary obstruction, and second slide is showing the tricuspid valve straddling. So in my group of the patient, there is a lots of aortic valve morphology. Among them, 4% has a TV straddling, 5% has a supramitral membrane, 5% has a common AV valve, and also 2% tricuspid atresia. So if I incorporate with our patient into the FOI classification, 1A is 16 patient, like 14% of the patient who has an committed VSD with a normally related great artery with a no RVOT obstruction like VSD type. And most of the patient, 41% patient in group B1B, which is non-committed VSD with a normally related great artery with a severe RVOT obstruction. So this is our surgery type. If I show you in a simple way, our surgical approach according to FOI, 1A mostly is the VSD type. So all the patient had a biventricular repair. This is tunnel repair from LV to aorta. And 1B, which is tetralogy of type, 43 patient who was on biventricular repair. One patient has a severe hypoplastic pulmonary artery. That patient needs stage palliation. 2A and 2B, which is non-committed VSD, normally related great artery with RVOT present and or RVOT not unobstructed. That is one who has that RVOT not obstructed. That patient was 7 biventricular repair, and 2B, which is RVOT obstruction. That patient was a 10 patient. 3A, which is committed VSD, malposed great vessel with RVOT obstruction, which is TGA variety. That was the 6th patient, and TGA VSD PS, which is the 3B, got the 5 patient. If I show you that what is the surgery done for that patient, 1A, all the patient had LV to aorta tunneling, and 1B patient tunnel LV to aorta tunneling also need RVOT resection, also need pulmonary valve creation. I would like to say our both surgeon has a very good creator of the pulmonary valve. And 2A, 2B, which is the non-committed VSD, then do the VSD enlargement and then an LV2 aorta tunneling. And the patient non-committed VSD with the normally rated greater artery with the RVOT obstruction, that patient also enlargement of the VSD tunneling, and after that creation of PV, and some patient need interventricular tunneling plus Rastelli. 3A, which is ASO, demalposed blood vessel, wherever did that arterial switch operation, and 2 patient was on side-by-side grade vessel, that patient only interventricular tunneling in done. And 3B, which is non-committed VSD, committed VSD with a malposed grade vessel with RVOTO, that patient need pulmonary root translocation. And 4A, which is very difficult in TGA variety, which is non-committed VSD with a malposed grade vessel with absent of RVOT. That patient, one patient, and they done the interventricular tunneling. After that arterial switch operation, mostly patient remaining patient was not in biventricular connection. They got in univentricular connection. So among the 107 patients, our mechanical ventilation duration, surprisingly 33%, which is tetralogy type, and some VSD type with a normal pulmonary pressure are on table extubation was 33%. 30% was on fast track extubation within 12 hours after extubation, and 37% need overnight ventilation. And among that 106 patient, mortality was only 1, and their mean hospital stay is only 5 days. So if we classified our DRV like a FUI classification, provides a clear anatomic characteristics of double outlet right ventricle, and surgical choice for DRV classification is very good for the surgeon. We can communicate with the surgeon very clearly. Thank you.
Thank you. Our next speaker is Dr. Abdul Jabbar Jibon from Bangladesh Shishu Hospital and Institute.
Respected organizer of the conference, respected chairperson of the session, and respected panelists and dear audience, a very good afternoon. I, Dr. Abdul Jabbar Jibon from Bangladesh Shishu Hospital and Institute, welcome to my part of presentation. Today, I would like to share with you 2 cases that I faced in last 3 months. Case 1, I nomenclature it as alien in the heart. Master X, a 10-month infant with known case of spastic quadriplegic cerebral palsy with global developmental delay, had history of neonatal intensive care unit admission due to parenteral asphyxia and was an prolonged time mechanical ventilation, had history of repeated respiratory tract infection, needs 3 times hospitalization due to pneumonia. On examination, child was tachypneic, having inspiratory stridor. First and second heart sound is normal, acyanotic, and there is no murmur. Chest X-ray was done. Heart is normal in transverse diameter and normal lung field. Refer to EchoLab to exclude any congenital heart disease or to check coronary arteries, as this is a COVID pandemic situation. Lots of new pediatric patients suffering from multisystem inflammatory syndrome and have coronary dilatation. When I did echocardiogram, the patient had an inspiratory stridor. Look at the ETP right ventricle. There is there is a linear echogenic shadow. I was confused. Could it be due to sound effect? The patient had a stridor. I was in confusion. What is this? And after giving Doppler echocardiogram, echo wind was not so good. There is a linear shadow is persisting across the RB and causing tricuspid regurgitation across the tricuspid bulb. I interpreted this may be a foreign body in RB cavity causing mild tricuspid regurgitation as well as RB systolic dysfunction. When I gave this report, PICU consultant annoyed me upon seeing this report, plan to reevaluate echocardiogram, what may be it. There is no recent history of CV-line cannulation. Reevaluation was done our head of the department and report was similar. Upon several query, mother gave history of typical cannulation 2 months back and a neckline was tried at that time. So chest X-ray was retrogradely reevaluated. There is a linear shadow across the in front of the heart. What can we do? Could it be CV-line guiding wire? Child is of cerebral palsy, compromised baby, wire may difficult to snare if attached to endocardium. There is chance of embolization also, and blame goes to a PICU team. That is another issue. After counseling of the attendants, we ship the patient to our cath lab. Yes, on AP and lateral view, that is where in the RB cavity, and it is free floating. That indicates it may not be anchored across the endocardium. And I snare it. When I snare it, my sympathetic activity, there is overactivation, where may goes to pulmonary artery and across the pulmonary embolization may occur. And finally, hold it and snared it and removed it. And after removal, it's a 20 millimeter in size, floppy part of the guiding wire. Actually, during cannulation, they tried to, for cannulation, they tightly remove the wire, then it's parts of, maximum parts of it remain within the heart. And post removal, angiogram and as well as chest X-ray showed there is no alien in the heart. And we discharge the child with sound sleep. Another case I would like to nomenclature at Lifeline in the little kids, a 6 days old unit having breathing difficulty associated with bruised discoloration of the body. On examination, there is central cyanosis, continuous murmur at right infraclavicular area. Saturation of oxygen was 50% in room air, 55% with 2 liter oxygen. Chest X-ray showed cardiomegaly, tilted apex, oligemic lung field. Echocardiogram done by renal periodic cardiologist. There is common source pulmonary atresia with large malaligned BSD. Small PDA in versus MEPCA dependent pulmonary circulation. Due to financial constraint, the patient was admitted at our cardiac ICU intensive care. Saturation was, baseline saturation was 50% after starting prostaglandin at the rate of 10 nanogram per kg per minute. Saturation slightly increased, but there is no significant change. So we plan for cardiac catheterization plus minus standing. So as the child is still alive, there should be a lifeline for survival. So go through the angiogram. Arch angiogram, there is no PDA, but there is a connection from descending aorta. And selective angiogram showed a MEPCA arising from descending thoracic aorta at T4 level. It keep branching as branch pulmonary artery. And there is severe restriction at the right hilar area. So we plan for stenting of the hilar area. There is no main pulmonary artery. There is no native branch pulmonary artery. Maybe this may be the final stage of the palliation. And we stent 4 into 20 millimeter cobalt chromium stent was deployed. And after deployment of the stent, there is increased flow of the lung vascularity and stent in situ, and chest X-ray showed good arborization of the peripheral hilar area. Pre-op echocardiogram, there's limited flow across the MEPCA, and post-op, there is increased flow through the MEPCA. And research the child with after establishment of lifeline with saturation of 85 to 90% in room air. I'd like to gratitude my sincere thanks to my cardiology team of Bangladesh Shishu Hospital Institute. Special gratitude thanks to the resident medical officer on duty and sisters on duty. And thank you all.
Thank you, Dr. Jobber. Now our presenter is Nahruma Abihada Choudhury from National Foundation.
Assalamu alaikum. Once again, welcome. I am Dr. Nahruma Abihada Choudhury, Assistant Professor in Pediatric Cardiology Department of National Heart Foundation. Today, I am going to share our experience on COVID-19 and congenital heart surgery. We know the COVID-19 pandemic has left an unprecedented mark on the world. As of 27th November 2021, over 262 million people have been confirmed with COVID-19 and leading to nearly 5.2 million deaths and counting. COVID-19 appears to have a complicated relationship with the cardiovascular system, and cardiovascular disease increases disease severity and mortality rate in those who are infected. Though the infectious risk to the pediatric population appears low, the effect on children with congenital heart disease remain poorly understood. So the objective of our study is to assess the impact of COVID-19 pandemic on congenital heart surgery and health system, and to see the demographic and clinical presentation of COVID positive patient related to congenital heart disease, and to see the early outcome of surgically treated of those COVID positive patients. So this is a descriptive study which was done in National Heart Foundation Hospital and Research Institute, and all the children who admitted for congenital heart surgery we included. And our study period was COVID period. It was 19 months, started from the April 2020 to October 2020. And the same period of prior to COVID we included, that was September 2018 to March 2020. And we have taken written informed consent, which was taken, and we are taken all the details of the patient, and we take the history and physical findings. And all the routine blood investigation and X-ray, ECG, echocardiography, and ultrasonogram of abdomen and brain was done. And we confirmed COVID by nasopharyngeal sample by RT-PCR test. And we admitted the patient initially. When the patient done COVID test and negative, we kept the patient in yellow zone. And again, we send the sample of the patient and patient's mother. And if they become negative, then we shifted to green zone. And if they become positive, mother or baby, we shifted to red zone. And we assess those patients clinically and biochemically and establish their treatment protocol. Now the result, this is the COVID curve of Bangladesh. And if we see the scenario of our surgery, we just compare and divide into two parts, 2020 and 2021, which started from the April. And if we see, we done only 1 cases in April and 6 cases in May. So initially it was not only the tough situation for the medical staff, it is also cumbersome and frightening condition for the patient. They cannot transfer, or there is a lockdown condition, so patient is not coming to our hospital, and surgery is also difficult because staying in the Dhaka is very difficult. And we, the medical doctors and staff, are in a dilemma how the surgery will behave if a patient is COVID positive, and how we will treat those patients when he become COVID positive, where to keep, how to treat, and what will be the effect of the management. So when we set a protocol, time is gone, and we set a protocol how to treat them, how to keep them, how to do surgery. We see that our number of cases increases gradually. And in 2021, the number increases more markedly. There is 2 decline during the Eid festival. And if we see in 2020, we have done 287 cases, that become almost double, 600, and total we admitted 887 cases. So the total number is 887. And if we see 53% of number cases increased when we set a protocol and we are used and accustomed with the condition. And mostly male, that is 67%. And if we compare this with the COVID and pre-COVID area, in pre-COVID time, we have done 1,247 cases in 19 months, and there is 31% reduction of cases. And this is the impact of COVID in our congenital heart surgery. And if we see the age distribution, in less than 1, it is 27%, and 1 to 5 year, it is 40%. So 67% operated we below the 5 years. What is the importance? I think this is the importance because we entertain the emergency cases, not the routine or elective cases. So under 5, it is mostly done. And the weight distribution also reflecting that below 10 kg, we have done 63%. And among these 887 cases, 33 patients become COVID positive, that is 3.7%. And mostly male is 61%. And this is the very good things that these among the COVID positive patient, mostly 80% are asymptomatic, and some 20% having the contact history with mild symptom like fever, diarrhea, or sore throat. And the disease pattern of this COVID positive patient mostly acyanotic, that is 53%, and that is VSD, ASD, and PDA. And 47% is cyanotic, mostly TOF, TGA, tricuspid atresia, TAPVC, and pulmonary atresia. And this is very important slide that though the patient having COVID with congenital heart disease, 91% we managed at home, only 9% need hospital management. And among these 33, we have operated 15 cases, which is 45%. Surgery was done. When they become COVID positive, we discharge them home, and they again come with the COVID test. And when they become COVID negative, we operated this patient. So these are the 15 patients that we operated, and these are the scenario. If we see that mostly this is acyanotic group, and I already mentioned that the patient which is becoming inoperable, that is mostly done VSD with severe pulmonary hypertension, large PDA like that. And the cyanotic group who are having spell attack or TGA type or obstructed TAPVC, we operated those group 40%. And the minimum age group, minimum age was we done 4 months, and maximum is 7.6, and less than 1 is 40%. And birth weight minimum is 4.4 kg, and less than 10 kg we operated 50%. And the ICU stay and hospital stay does not truly reflect the COVID with congenital heart disease, because the complexity of the disease itself and the surgical intervention also, and COVID also kept an impact on these ICU stay and hospital stay. So we cannot bring a conclusion to this. And there are lots of complications like arrhythmia, fistula, and severe ventricular dysfunction, atelectasis, low output syndrome. That also we cannot give a concluding remark on COVID with congenital heart disease. And if we see the outcome, 87% discharge. And though it is seen that death rate is higher, 13%, I am telling that we mostly included the toughest case and emergency cases we entertained. So I think the death rate is a little bit higher in these. So summary, 31% reduction of cases is compared in pre-COVID period. COVID positive cases is 3.7%, 67% operated below 5 years and 63% below 10 kg, and minimum age group is 4 months, and 80% COVID positive patient is asymptomatic, 53% patient are acyanotic group, 91% managed at home, and we discharge 87% and death is 13%. So take home message is there is paucity of the data regarding COVID-19 in patient with congenital heart disease, and there are no clear guidelines regarding the management of COVID-19 in patient with congenital heart disease. Decision had to be made on a case-based basis, and most patients receive different care. Strong conclusion cannot be drawn regarding the causality between the congenital heart disease and outcome of the patient. Thank you all.
Thank you. Now our next presenter is Dr. Sumaira Nasrin from NICVT.
Assalamu alaikum and good afternoon. I'm Dr. Sumaira, working as assistant professor in the Department of Pediatric Cardiology, NICVT, Dhaka. This is the story of Mim, a 9-year-old girl. Mim was diagnosed as moderate perimembranous VSD at 3 months of age, while she has a first attack of pneumonia. Since then, she was on regular follow-up and medication. Subsequent follow-up on later days, echocardiography shows VSD became smaller, guarded by STL and aneurysmal septal tissue, no RCC prolapse or air. Advised to close the hole at 4 years of age, but economical background does not permit. But she continued to visit our OPD with follow-up, took medication, and all the dental hygiene were maintained. But she lost for follow-up for the last 2 years due to the pandemic situation. For the last 4 months, Mim developed intermittent fever, general malaise, myalgia, weight loss. She was treated locally without any improvement, and in our OPD on admission, we found her febrile, pale, and cachectic. The cardiovascular system examination reveals S1, S2 is normal. There is a pansystolic murmur at left lower sternal border. This is the blood picture. Hemoglobin is 5.7 gram per DL. There is neutrophilic leukocytosis. Platelet count is low. ESR and CRP is high. There's plenty RBC in the urine, and others are not give any findings. And blood cultures, we sent 3 cultures from different sites on 24 hours, but there's no growth. And on repeated blood culture, there's also no growth. This is the echocardiography of Mim. We are seeing that the small perimembranous VSD. The shunt is completely left to right shunt. Sorry, the video is not running. I'm sorry. But while we are seeing the apical four-chamber view, the apical four-chamber view, there is two large vegetations are seen on the RV side and attached to the septal leaflet of the tricuspid valve and also on the anterior tricuspid leaflet. Both the vegetations we measured, it is about 17 millimeter long and 7.85 millimeter in its width. So started blood transfusion, we gave the platelet transfusion and started the empirical antibiotic regime, injection ceftriaxone and gentamicin. But after 2 weeks of injection, she does not subside from fever and general conditions are also not improving. Moreover, when we are seeing the echocardiography, two large more vegetations are seen on the pulmonary side. And they produce mild RVOTO. Both sizes are more than 17 millimeter. So we started the antifungal. We started we did not find any growth on the blood culture. So we thought that it may be enterococci or staphylococci. So staying with our regime on the ceftriaxone and gentamicin, we included the meropenem and we decided vancomycin, and we decided to continue the regime for 6 weeks. So what will you do now? Will it resolve with this antibiotic regime? Should we wait for the 6 weeks before sending for surgery? Should surgeon take the challenge to remove this vegetation? Key message is we are always fearful for the large VSDs. They are our prime concern as they cause the heart failure and they cause the pulmonary arterial hypertension. But small ones can end with the deadly complications. Approximately 5 to 10% of patients with IE have negative blood cultures. Culture negative IE should be considered when clinical or echocardiographic evidence of IE present, but blood cultures are repeatedly negative. This is the case 2. Saw the 5 months old presented with breathing difficulty and feeding difficulty. On admission, baby was found dyspneic, having tachypnea and tachycardia. First and second heart sound normal. There's pansystolic murmur at the apex. Breath sound normal and no added sound was found. She was diagnosed outside a severe MR and got fusimide and referred to our OPD for further evaluation. So when we did the echo, we found the hugely dilated LA and LV. The video. The MR is severe with hugely dilated LA and LV. But then we got the first clue. In the short axis view at the papillary muscle level, we found that sclerosed, hyperechoic and calcified the anterior lateral papillary muscles. The short axis view, we are able to see the right coronary artery arising from the right coronary sinus. I highlight it so that I thought that from the large benches we'll see it from behind, but all the chairs are empty. But when we are trying to locate the left coronary sinus and the left coronary orifices, we did not find anything from the short axis view. With some tilting and anti-clockwise rotation, we are able to found the LCX and LAD both are arising from the posterior sinus of the pulmonary artery. The LCX and LED both are seen from arising from the posterior coronary sinuses. Color flow shows the reversal in the LCX, the red color in the LCX and blue color in the LED. We did an ECG and we find the pathological Q wave in 1 AVL and V4 to V6. So this is a diagnosis of L-kappa, which is a rare congenital anomaly. Symptoms appear within 10 weeks of life, consisted of paroxysmal attacks of discomfort precipitated by feeding, compatible with life if associated with pH or extensive collateralization. Echocardiography has a key role to diagnose. Clue to diagnose L-kappa on echoes are dilated RCA and the absence of LCA from the left sinus. Classic short axis view may sometimes give false impression. Tilting and anti-clockwise rotation of the transducer will help, and detection of flow reversal in the pulmonary artery. So in all infants and children with unexplained LV dilation and severe mitral regurgitation, we should think of the abnormal coronary orifices. And in these cases, we got the first clue from the short axis view at the papillary muscle level, that scarring of the papillary muscle evidence as bright hyperequation. What more we can be done? We can do the aortic root angiography, selective right coronary angiography, and selective left coronary angiography to diagnose the case. Thank you all.
Thank you. Our next presenter is Dr. Shirin Kobir from National Foundation Hospital.
Okay, Assalamu alaikum and welcome you all again. We are almost at the end of our session, so everyone is almost very tired and almost ready to go to home. So I am going to be a very short presentation. This is a child with a very unusual coronaries that we encountered last year. This child, 1 year, 8-month-old female child weighing 8.9 kg. She came to us with irritability, shortness of breath, and bluish discoloration. On examination, we found the child was having failure to thrive. She was cyanosed with saturation 65%. Early clubbing was prominent. There was a continuous murmur in the left sternal area and in the back. So this is the echo loop showing, this is the apical 4-chamber view, showing there's a large atrial septal defect, which had a right to left shunt. And you can see the RV is hyperplastic with hyperplastic tricuspid valve. So the tricuspid valve annulus was 8 millimeter. The Z-score was -3.5 standard deviation with hyperplastic in RV. And this is the short axis view showing there is no antegrade flow through the RVOT into the PA. Rather, there was a large PDA feeding the pulmonary artery retrogradely. And on the same short axis view, we can see the right coronary artery being dilated, and it was +9.86 standard deviation. And the left coronary artery was having also a large aneurysmal dilatation. So this was a case of pulmonary atresia, intact ventricular septum with PDA-dependent pulmonary circulation with hyperplastic RV. So in this case, can this case go for univentricular repair or biventricular repair? So we have to make a decision. And so we did the cath of this patient to see if biventricular or univentricular palliation is the choice, and to see if there is any coronary abnormality. So this is the LV angiogram.
in the LU view with a pictorial catheter in the LV. And you can see that there is a right coronary artery being dilated. You can see the dilated right coronary artery over here. Left coronary artery cannot be seen very nicely. And this is the root angiogram showing also the right coronary artery being dilated over here. And same here, the left coronary artery is not well visualized. And if you see very carefully, you can see the right coronary artery being interrupted up to, at the distal end. And somehow it does not go up to the apex. So let's have a clear 2D picture over here. And here you can see the right coronary artery being interrupted, and there's a clear interruption over here. So let us look more. So let us recapitulate our idea on the coronary artery system of the heart. So this is a picture showing that the right coronary artery is arising from the aorta, and the left coronary artery which gives off branches to the left circumflex artery and the LAD. The LAD is actually sits on the interventricular septum. So finding the LAD means finding the interventricular septum or vice versa. And this is the live picture from the heart after being sternotomy done. And this is the interventricular septum on through which the LAD passes. And this is the surgeon pointing us to the LAD. So we pediatric cardiologists, we somehow are less interested, maybe a little less than the adult cardiologists, but we should have a clear-cut idea about which artery to see where. So this is a coronary angiography basic views. Is a top review article published in 2018 saying about which coronary arteries to be seen where. So this is in the AP frontal view showing that the left coronary artery, left main artery, which divides into left LCX, L6 over here, and the LAD. And if we take a iliocranial view, we see the LAD, which comes perfectly perpendicular down with the with the L6 on the right side and the diagonal on the left side. So it helps us to give a clear delineation to find out which arteries are seen where. So similarly, in this patient, we started off with, we started the, I'm sorry. This is the RV angiogram of the through a Berman catheter, and you can see the RV is very hyperplastic, and very, very interestingly, the distal portion of the RCA, which was seen to be interrupted in the root angiogram, is seen to be filled retrogradely from the RV to the coronary arteries. And also very, very interestingly, you can see the left anterior descending artery and the L6 over here supplied from the RV. So the RV is supplying retrogradely both the coronary arteries of the heart, that is the right coronary artery and the left coronary artery. This is a still picture showing, this is the LAD. So this hypertensive RV is supplying both the coronary arteries of the heart, and therefore it is very, very crucial that it maintains this hypertensive sensitivity, this hypertension to maintain the coronary flow of the heart. And this is the left lateral view showing the showing that the PDA, which will arise from the aorta and supplying the right and left pulmonary artery. So what is RVDCC? So this was a case of RVDCC, that is right ventricular dependent coronary circulation. It is defined as the presence of any coronal cameral fistula with coronary obstruction proximal to the fistula and angiographic evidence of RV perfusion of the myocardium through the fistulous communication. To the Banglai boli, ব্যাপারটা এটাই যে সামনে একটা proximal obstruction থাকবে aorta থেকে, ওইটার জন্য আরভি, এই হাইপারটেনসিভ আরভিটা থেকে কিছু ব্লাড ভেসেল গ্রো করবে থ্রু সাইনোসয়েডস অর এনি আদার ফিস্টুলাস কমিউনিকেশন, যেটার মাধ্যমে এই আরভি থেকে হাই প্রেসার দিয়ে এই কর্নিয়া আর্টারিটা সাপ্লাই করবে বোথ আরভি and sometimes also LV perfusion. And it is common when the RV is hypoplastic, unipartite, and the chances of having this RVDCC is proportional to the degree of hypoplasticity of the tricuspid valve. That means more the hypoplasticity of the RV valve, of the tricuspid valve, more is the chance of these patients having RVDCC. And the coronary artery abnormalities which requires our right ventricular blood flow are where there is absent aortocoronary connection, where there is coronary interruption or stenosis, or there is profound coronary cameral steal or fistula. And this retrograde coronary artery blood flow from the hypertensive RV during systole through the ventricular connection is necessary for myocardial perfusion. But why do we have to know about RVCC? Why is it so important? Because if surgical or transcatheter RV decompression is done in the setting of significantly dependent myocardial infarction, myocardial circulation, this will lead to the RV, will lead to ischemia. And this patient in our, as this patient had RVDCC, this patient, she underwent univentricular palliation, that is BD Glenn, and she was sent home with a good heart. Thank you all.
Thank you, Dr. Shaheen. Now our today's last speaker is Dr. Santosh Kumar Saha.
Respected chairperson and the learned audience, welcome to my presentation on a research paper. This is the original research paper and the title is Prevalence of Congenital Heart Disease Among Under 5 Rural Children of Bangladesh. And this is the first population-based study in Bangladesh. Congenital heart disease is the most leading cause of premature death and disability in children of Bangladesh. And if we ask a question to the audience, what is the magnitude of the problem of the congenital heart disease in Bangladesh? The answer is not known because we have no data regarding the prevalence of congenital heart disease in Bangladesh. So that's why this study is very much time demanding to make a prevalence rate of congenital heart disease in Bangladesh. Unfortunately, we have no community-based data, but some hospital incidence is there. In 2008, NN Fatima et al. Showed the incidence of congenital heart disease is 25 per 1,000 live birth. But this is, remember, this is the hospital incidence, not reflect the community level. And another study in the Mymensingh Medical College shows that the hospital incidence of congenital heart disease in UNAT is 7.8 per 1,000 live birth. These are all hospital incidents and does not reflect the national data. So it is necessary to know the exact prevalence of congenital heart disease in Bangladesh to estimate the burden of congenital heart disease and so that the government can take the necessary action to prevent this congenital heart disease as well as prevent the mortality and morbidity. So our objective of this study was to estimate the prevalence of congenital heart disease among under 5 rural children of Bangladesh, to assess the clinical pattern, distribution or type of congenital heart disease among under 5 children, and to know the socio-demographic profile of the congenital heart disease children. It was a cross-sectional survey, and the study was done over the last 6 months, January 2021 to June 2021. And this study was done in the selected rural area of Manirampur Upazila of Jashore district. You know that this is on southwest region of the Bangladesh. The study was conducted by the Department of Pediatric Cardiology, NICPD. We include all the under 5 children of the selected area, and those children are not willing enroll in the study, and also absent children on the day of data collection are excluded. We registered approximately 3,065 children, and out of them, 2,010 children are ultimately take part in the screening procedure, and our dropout rate was 25%. Now, what is the sampling technique? We purposely select the Monirampur Upazila, one of the largest Upazila of the Jashore district, having the 17 unions. And from these 17 unions, by the random sampling procedure, we select the 2 unions, that is Dhakuri and Haridaskati union by lottery method. A standardized questionnaire developed, advocacy meeting was conducted with the local chairman, members, and elite society, and also the imams of the mosque and the priest of the temple and the civil society. Then we recruited 10 data collectors and we trained them appropriately. Data collector registered all under 5 children of selected area within short data form and containing demographic information, and then invite them to nearby primary or secondary school in a specific date for screening of congenital heart disease by pediatric cardiologist. Those children having the abnormal appearances or cleft lip or palate, syndromic patients, patients having clubbing, and the low saturation, abnormal heart sound, and or murmur are selected for taking the detailed clinical history and physical examination and echocardiography. Echocardiography was done by pediatric cardiologist using Philips portable cardiac ultrasound machine. And if the children having there is a small PDA without the volume overload of the left ventricle, or there is PFO, or there is a small SD less than 3 millimeter without the volume overload of the right ventricle, or there is branch pulmonary artery, mild turbulence in the branch pulmonary artery, they are considered as normal. They are not considered as congenital heart disease. And prior to commencement of the study, this protocol was approved by the Institutional Review Board of the National Institute of Cardiovascular Disease and Hospital. And after the data collection, appropriate analysis was done. Now, this is the result. We registered 3,065 children. Ultimately, the 2,310 children are included in the study. And most of the children are 1 to 5 years old, about 87%, and rest of them are infant and neonate. And approximately male and boy children are approximately equal. And they are come from mostly from the low middle income society, and few are from lower class, and approximately very few in middle class family. And from these 2,310 children, approximately 98 children undergone echocardiography. And about this, from these 98, we found that 25 children having the congenital heart disease, and 30 children having the persistent foramen ovale, and 43 are normal. And the overall prevalence rate of congenital heart disease under 5 children are 10.8 per 1,000. And with a confidence interval is 7 to 15.9. And most common congenital heart disease was the ASD, and thereafter the VSD and PDA. We found only 2 cases of cyanotic congenital heart disease, both are top. So friends, in conclusion, we can say that prevalence of congenital heart disease among under 5 rural children of Bangladesh is approximately 10.8 per 1,000. And this is being the first reported prevalence from Bangladesh. And the commonest lesion was atrial septal defect by 44%, and rest of them VSD and PDA. And my limitation of study was, it was a small sample size and a selected rural area. Thank you very much.
Thank you. This is the time for discussion. Now, you have any question, you can ask to the presenter. Okay.
Assalamu alaikum. Thanks. It was a nice session, actually, a good presentation. So I have 2 questions to 2 presenters. First, Dr. Jasmine Hussain, I just want to know, DRP diagnosis actually really challenging many of the times, DRP diagnosis. So what is the percentage of discrepancy between funding of cardiologist and per operative funding by surgeon?
আমি আমার এই স্টাডিতে ইকোকার্ডিওগ্রাফিক ফাইন্ডিংস অফ ডিসক্রিপেন্সি বিটুইন দ্য সার্জন অ্যান্ড পারাপাটিভ অ্যান্ড দ্য ইকোকার্ডিওগ্রাফি এটা শো করি নাই, কারণ এই ডিসক্রিপেন্সিটা আসলে আরো খুব ইলাবোরেটলি দেওয়া উচিত। আমাদের সার্জনস নোটে অনেক কিছু থাকে না, আবার আমাদের ইকোকার্ডিওগ্রাফিতে আমরা অনেকেই কোনাস আছে কি না, বায়োল্যাটারাল কোনাস, সাবপালমোনিক মানে ভিএসডি, কমিটেড ভিএসডি, নন কমিটেড ভিএসডি, মোস্টলি 90% is correct. More than 90% is correct. Greater relationship, more than 94-5% is correct. RVOT obstruction 100% is correct. But in simple জিনিস, more tough জিনিস like bilateral conus, how far the VSD is from the greater artery, এই ছোট ছোট জিনিসগুলা আমি প্রত্যেকটা 107টা সার্জন নোট ঘেটে দেখছি যে অনেক সময় আছে যে সার্জন উল্লেখ করে না, হয়তো ছিল না ডিসক্রিপেন্সি, উল্লেখ করে নাই, সো পরে এই জন্য আর এটাকে আনি নেই, এই স্টাডির মধ্যে নিয়ে আসিনি।
জেসমিন, তুমি তোমার প্রেজেন্টেশনটা অনেক সুন্দর করেছো।
থ্যাংক ইউ স্যার।
যেহেতু ডিআরভি লাইজ ইন বিটুইন টফ এন্ড টিজিএ, সেজন্য এখানে শেয়ারিং হবে, এই টিজিএ টাইপ হবে, টফ টাইপ হবে, সিম্পল ভিএসডি টাইপ উইথ জিআরভি উইথ রিমোট ভিএসডি, অনেকগুলো ইয়ে আছে, এবং ম্যানেজমেন্ট সার্জিক্যাল আউটলাইনও ডিফারেন্ট।
জি স্যার।
তো থ্যাঙ্কস ফর ইউর প্রেজেন্টেশন। কিন্তু তারপরে একটা কথা রয়ে গেল, আমি প্রেজেন্টেশনের মধ্যে তোমার একটা স্লাইড দেখলাম, সেখানে তুমি দেখিয়েছো অ্যাওটোমাইট্রাল ডিসকন্টিনিউটি। এটা কি এই ব্যাপারে তুমি কি অ্যাওটোমাইট্রাল ডিসকন্টিনিউটি যে ছবিটা দেখিয়েছো এটা কি সঠিক? ইজ ইট ওভাররাইডিং মোর দ্যান 90% উইথ অ্যাওটোমাইট্রাল কন্টিনিউটি, আর তুমি এটা অ্যাওটোমাইট্রাল ডিসকন্টিনিউটি বলবা যে ছবিটা দেখিয়েছো?
সম্ভবত ছবিটা আমার অ্যাওটোমাইট্রাল ডিসকন্টিনিউটি ছিল, ফাইব্রাস ডিসকন্টিনিউটি। Automatral discontinuity is two types. One is fibrous discontinuity, one is muscular discontinuity. There is a no muscular
discontinuity, the remote VSD তাই muscular discontinuity অনেক দূরে চলে যায়। কিন্তু অ্যাওটোমাইট্রাল discontinuity means aortic valve এবং mitral valve যদি বাচ্চাদের বেলায় মোর দেন 5 এর উপরে যদি ডিসকন্টিনিউটি থাকে তাহলে, আর যদি অ্যাডাল্ট হয় তাহলে 11 মিলিমিটার পর্যন্ত আমরা বলি। অর্থাৎ অ্যাওর্টিক ভালভ এবং মাইট্রাল ভালভের যে জাংশনের এই ডিসটেন্সটা, কিন্তু আমার কাছে তোমার ওই ছবির প্রেজেন্টেশন থেকে মনে হচ্ছে it is less than 5. So it is not discontinuity, it is overriding 90%, and 90% overriding DRV with automatral continuity it is nicely correctable, easily correctable by surgeon. So this is the message. Okay, thank you.
If I am allowed to ask another question, I want to know from Dr. Sumaranas. So your patient actually, it could be as repeatedly.
Actually 90% overriding এটা easily correctable, এবং এটাকে টপের সাথে এটা easily correctable, এবং মাথায় আমাদের রাখতে হবে যে এটা সার্জারি করা যাবে। এই কন্টিনিউটি, অটোমেট্রাল কন্টিনিউটি উইথ 90% ওভাররাইডিং, তুমি যে ছবিটা দেখেছো দ্যাট ওয়াজ 90% ওভাররাইডিং, isn't it? হ্যাঁ, এটা কি সঠিক ছিল? তুমি যেটা দেখিয়েছো এটা 90% ওভাররাইডিং উইথ অটোমেট্রাল কন্টিনিউটি, তো তুমি ওখানে উল্লেখ করেছো অটোমেট্রাল ডিসকন্টিনিউটি, এই জন্য আমি ব্যাপারটা অ্যাটেনশনে আনলাম। না, এটা ফাইব্রাস না, এটা হলো অ্যাওর্টিক ভালভ আর মাইট্রাল ভালভের ডিসটেন্স। হ্যাঁ, এটা হলো ডিসকন্টিনিউটি আর কন্টিনিউটি। হ্যাঁ,
in DRV there is a maybe bilateral conus also, that is aortomitral as well as pulmonary mitral discontinuity, both can be happen, or single.
My question to Dr. Sumaira, did you think about actually antifungal fungal cause of infective endocarditis, that you are getting repeated cultures are negative, and did you try for actually fungal culture? I just want to know if you tried for fungal culture.
No, we don't send for the fungal culture, as the vegetation is growing in spite of getting the antibiotic, and patient is not subsiding, so we thought that we should start the antifungal.
So Sumaira, what was the dental status of your infective endocarditis baby?
Was not maintained, sir.
Dental hygiene was not maintained. নবী করিম সাল্লাল্লাহু আলাইহি ওয়াসাল্লামকে বলা হলো যে ইয়া রাসূলুল্লাহ আপনি আমাদের একটা ভালো ব্যক্তিগত অভ্যাসের কথা বলেন। নবী করিম সাল্লাল্লাহু আলাইহি ওয়াসাল্লাম কি উত্তর দিয়েছিলেন সেটা কি তোমরা জানো? আমি যদি তোমাদের কোনো ভালো ব্যক্তিগত অভ্যাসের কথা বলি তাহলে 5 বেলা দাঁত মাজতে বলবো। আজ আমরা হার্ট ডিজিজ, ভাস্কুলার ডিজিজ, কনজেনিটাল হার্ট ডিজিজ যাই বলি না কেন সব জায়গায় কিন্তু আজ ডেন্টাল হাইজিনের কথা বলা হচ্ছে। সেই 1400 বছর আগের কথা বলা হচ্ছে, বই খুললে এটাই দেখা যায় চ্যাপ্টারের শেষে, ডেন্টাল হাইজিন এন্ড আই প্রোফাইল্যাক্সিস। সেটা আমাদের মাথায় রাখা খুবই জরুরি কনজেনিটাল হার্ট ডিজিজের পেশেন্টের।
থ্যাংক ইউ।
জাস্ট আমার একটা যে যদি সাবঅ্যাকিউট ইনফেক্টিভ এন্ডোকার্ডিটিস পেশেন্ট যদি খুব সিম্পটোম্যাটিক না থাকে, খুব টক্সিক না থাকে, তাহলে অ্যাকচুয়ালি অ্যাটলিস্ট 48 আওয়ার্স অ্যান্টিবায়োটিক স্টপ রেখে যদি আমরা কালচার করি, মোস্ট অফ দ্য কেসে উই গেট সাম গ্রোথ and also we send fungal stain at the same time for after 48 hours discontinuation of antibiotic.
If I, with the permission of the panel, I want to add one thing to the question of overriding. So in a case, DRV is a difficult surgical case. So as a surgeon, what we take into consideration actually, degree of overriding is not a very good concern actually. The distance between tricuspid annulus and pulmonary annulus is the main concern. It's a big concern actually. And relationship of the great arteries and location of the VSDs, and more is this actually, whether you will be able to tunnel this VSD to the aorta. That depends on the distance between the tricuspid annulus as well as mitral annulus. So actually that has also been challenged in the classification that was shown actually, because with the same location of VSD, with the changing relationship of the great arteries, the name of the VSD is changed, subaortic subpulmonary. If you, in a normal related great arteries, a subaortic VSD will change when the relationship is reversed. It will become a subpulmonic VSD. So relationship to great arteries and location of the VSD are the variables which varies. So on the basis of only these two, you cannot say. The fundamental thing actually, the distance between tricuspid annulus and pulmonary annulus from the VSD, whether you can channel it to the aorta. The particular thing I wanted to say is the question in regard to the short annulus and 90% overriding that you are discussing actually. Probably in those cases actually, the other question that I said, issue that I have raised, the distance, probably that patient went into a switch procedure or simple VSD closure will do actually. Because we don't know particularly from that echo, where is the pulmonary artery? It's a DRV with 90% overriding, and then where is the pulmonary artery? Yeah, otherwise, actually, it should not be. So it is just a simple VSD closure, probably with a tunnel tile like thing actually. But if that relationship is not normal, then what? Is the great vessel relationship is not normal?
If it is not normal, normally related, it is very difficult to.
That is actually.
It is very difficult to do total surgery. So issue is aortomitral continuity with 90% overriding with normally related great artery.
It is 99% 99% situation. This will be a normally related great artery.
Yeah, it is.
That's what.
That is the issue. But here is the some dilemma. It's still
dilemma is actually.
That's why I have raised this.
What you raised actually, there is you have not seen that there is aortomitral discontinuity in the echo, and what she mentioned is discontinuity. So if it is discontinuous, then we have to think differently actually. I don't know.
If it is in aortomitral discontinuity with normally related great artery, still it is by some surgeon are doing total correction.
In that case, actually, you have to take the distance between pulmonary artery.
Yeah, that is with some discontinuities, it is still with normally related great artery is still possible. It's still possible.
Okay.
issue. That is this issue. With TGA, with LTGA, it is not possible. TGA type, it is not at all possible. Right. It is a spectrum actually.
I would like to ask the surgeons whether they are comfortable with this type of classifications, or they would like to have descriptive type of echo, like the whole echo. They would like to good description.
I think a description is helpful to us more. So mere level of diagnosis doesn't help. This is for sure. And there are another group that Jasmine has not brought actually. It's called, it's a French group actually. They do not agree to the old traditional classification of overriding and anything. Their main concern is the size of the VSD, whether there is pulmonary stenosis or not. And the main thing is the distance between tricuspid annulus and pulmonary annulus. And they have made two possible repair technique. One is you can either go to switch operation or do biventricular repair. In some cases, you need pulmonary intervention, or in some cases, you don't need. So the main thing is actually whether they disagree all these things. And probably Dr. Shahrin can tell you, because there is a big article they have written, surgical synthesis of DORV. So DORV patient ki kore surgically synthesis korte hobe, how to explain, and this is a good article. And we prefer to that. We prefer description rather than leveling. Thank you.
One more thing that I ask sometimes Dr. Shiva Kumar. So sometimes that great artery relationship, whether we will tell the great artery relationship at the valve level or at the great artery level. So he said that you describe at the valve level, sometimes we get valve level, this is side by side, but on the great artery level, something different. So he said that you describe at the valve level how the great artery is related. Then also you again describe at the great vessels level that how it is related.
It is always at the annulus level. Okay, that matters. The only two thing in the heart that is probably fixed, others are variable. The annulus, tricuspid annulus, mitral annulus, these are the only fixed things. Others vary. Location of the VSD vary, annulus of the aorta vary, annulus of the pulmonary artery vary, conal septum varies. So blood vessel relationships, even this varies. So
the level of the annulus is enough.
At the levels of the annulus, you have to describe everything in relationship with the pulmonary, mitral annulus and tricuspid annulus, because other structures keep varying. Malposition of the arteries, location of the VSDs, location of the conal septum, all varies. So that cannot be a reference point. That's why the French group actually, they are concentrating on the fixed thing of the heart. What are the most fixed things on the heart that can be referred as a reference point? So they have excluded everything, that all are varying. And among that two variables, one is fixed tricuspid annulus, another is pulmonary annulus. They have taken these two for granted. If there is enough space between these two, and you can tunnel the VSD to the aorta, rest can be tackled. If there is tricuspid pulmonary continuity, then you have to do a TGA. They have said simple. If the distance is large, you can take the VSD to the aorta, the biventricular repair. But their classification is very straightforward, and they have described the futility of this different methodology, alignment, connections, relationships. And they have shown the single location of the VSD has 8 different level, and said this is not applicable.
It will remain. Last year, I have seen a presentation of an Indian presenter, the surgeon underwent univentricular repair. Glenn shunt has already been done, and after that, they have done biventricular repair. You have seen that presentation. So still it is a dilemma.
So my question is, in case of remote VSD, with adequate size of pulmonary artery, what is your strategy for surgical correction?
Sir, the definition of remote is very perplexing. When we say remote, so there is a definition. So এটা ফুয়ের যে ক্লাসিফিকেশন আছে সেটা বেসড অন দ্যাট থিং, বাট আমার কাছে যেটা মনে হয় রিমোট ইজ বাই নেচার ইজ রিমোট, বাট এই রিমোসিটির ডিস্টেন্সটা যদি কম হয়, স্যার আমরা যেসব পেয়েছি যদি আপার মাসকুলার হয় উই টানেল দেম, আইদার ইফ ইট ইজ সাবপালমোনিক উই
Okay, learned audience and all the presenters.
নাকাতা ইংলিশ ছাকাতা না, আমরা ফলোই করি না, সরি উই ক্যানট কমেন্ট অন দ্যাট।
All the actually we are running short of time. Sorry, this discussion will be we can say continuous process of argument and discussion. As there is a two days more conference, we can discuss among ourselves. All the presenters presented very nicely, and almost all of them maintained their time, and contents was very good. Actually, it is very difficult for us to select who will be the first, second, and third. But for the sake of giving the prize, we have to select. So Professor Tuhin Haq, she will announce the winners, total 3 winners, first, second, and third. And there is also a prize for the best questionnaire. Most of the question is asked by Dr. Hassan. So undoubtedly, this prize will go to Dr. Hassan.
I'd like to congratulate all, and especially for the participants who stayed till the end of the session. And as Dr. Samsuddin, Professor Samsuddin mentioned that only question was from Dr. Hassan. So he will get the best questionnaire award. And for the guest presenter award, there was a very tough competition, and averaging the all marks given by us, I will start from the 3rd position. So the 3rd winner is Abdul Jabbar Jibon from City Hospital. And 2nd winner is, okay, you take your award, please. Owner certificate will send later, okay? Okay. And the 2nd winner is Shantosh Kumar Shaha. Congratulations. And the first, Shireen Kabir. Now it's a complete chilo.
আমাদের কমিশন Samsudin. Now I will request Dr. Zakia to conclude the session.
We can say Dr. Lieutenant Colonel Nazmul Hussain Bhuiya was being with us throughout the session. I will tell him to say a few words and we'll conclude after that. We cannot hear you. Please unmute yourself.
Thank you very much, Professor Shamsuddin. Honorable Chairperson of the conference, respected panelists, and my dear audience, Assalamu alaikum and very good evening to you all. It's a great honor and rare privilege for me to be a part of this conference. I had a great desire to take part actively. Due to some official formalities, I could not join actively. I apologize for that. However, all the participants has presented very well. They all were well conversant. They were fluent. Text was excellent. Topics were very much relevant and time demanding. Presentation skill was very good. However, it's a competition, so that we had to make someone first, second, or third. And I have already prepared my result sheet, sent it, and accordingly it has been declared. And I am very much happy to be a part of your conference. Thank you again. Thank you all.
Now, I would like to request the other presenter of the session to collect their certificate and memento. Please, Dr. Jasmine Hossain.
Attention, please, Dr. Jasmine.
Dr. Jasmine
You are
Hossain, come to
requested
the dais.
to collect your memento.
Dr. Nahruma Ibihada Chaudhuri. And Dr. Sumaira Nasreen. Now, I'm requesting Professor Tuhin Haq Madam to give the memento to our honorable faculty member. First to Professor S.K. Rajak sir. Now, Professor Umme Jakia Nasneen, Associate Professor Umme Jakia Nasneen. Now, I'm requesting to come to the dais Dr. Rizwana Rima to collect the memento. Okay. Now, Professor A.K. Samsudin, sir. John? Now, I would like to one person from the Beacon Pharma to give the presentation to the best questioner to Dr. Hassan. নিয়ে যাবো। Okay, thank you. Thank you all. Now we conclude our session. Thank you. ফটো সেশনের জন্য একটু থাকেন।